Thought I had it on. Just like yesterday, today's meeting is being streamed online for anyone who'd like to tune in and follow along. We're also fortunate to have stakeholders and members of the public joining us here in person. Thank you all for being here. I wish we didn't have it set up like this, which is all of us not facing you. It means a lot to have your participation and engagement. There will be public comment periods throughout the day for anyone who wants to share their thoughts. As yesterday, you can make public comment over the phone by calling 1-800-259-4105. Members of our stakeholder relations team will be standing by to assist. So I'm going to go over a little highlight of today. The majority of our day will be focused on healthcare, starting with some action items to review and approve the pharmacy benefit manager contract for 2026 through 2030 and the 2026 health premiums for our HMO and PPO plans. Then we'll look at the proposed employer contribution formulas for the state annuitants, followed by premiums for our association plans, including the California Association of Highway Patrol, the California Correctional Peace Officers Association, and the Peace Officers Research Association of California. After those items of business, we'll transition to clinical update about improving health outcomes for members with chronic disease states, along with efforts to expand access to behavioral health services access. We'll wrap up our health discussions with a session on a potential AI and its impact to the health industry. After lunch, we'll get an update on the priorities in our 2022 strategic plan, 2022 to 27 strategic plan, hearing from leaders across the organization. And finally, we'll wrap up the open session today with a cybersecurity update. So with that,
President Taylor, would you like to take roll?
yes, thank you.
Teresa Taylor,
Here.
David Miller. Here. Deborah Gallegos for Maria Cohen. Michael Latoy.
Here.
Frank Terfino for Fiona Ma. Present. Elena Ortega. Jose Luis Pacheco. Kevin Coffey. Morning. Ramon Rubalcaba. Yvonne Walker. Melissa Willett. Dr. Theo
Are you
Willett.
going to say anything?
No.
Okay.
No. Grab it.
Okay, thank you. So with that, now that we've had roll, I'm moving into this already. That was really quick. So with that, let's get started with the pharmacy benefit manager contract from 26 through 30. Here to present are Dr. Julia Logan, the Chief Clinical Director in our Clinical Policy and Programs Division, and Rob Jarzombic, Chief of our Health Plan Research and Administration. Thank you.
Thank you, and good morning, President Taylor and members of the board. Julia Logan, Chief Clinical Director, CalPERS team member. I'm here today to provide you with staff's recommendation to the board for CalPERS outpatient pharmacy benefits vendor, serving our PPO basic and Medicare supplement plan members and many of our HMO basic and Medicare Advantage plan members starting January 1st, 2026. Our current outpatient pharmacy benefits contracts through a self-insured arrangement with OptumRx provides benefits to approximately 587,000 of our members and comes to an end on December 31st of this year. Before I provide you with our final vendor recommendation, I'm going to be giving you an overview of the goals and objectives that drove our efforts and the process that has gotten us to this point. As a refresher, our three main objectives for the 2026 pharmacy contract are to foster affordability for CalPERS and our members, ensure access to safe and effective medications, and provide full transparency regarding the terms and arrangements between CalPERS and our pharmacy benefits provider. These objectives reinforce our ongoing commitment to member choice, safety, and prescription drug access. We intend to build on what we adopted for our HMOs and PPOs to align a pharmacy benefits vendor's bottom line with CalPERS' financial and quality goals in providing the best possible care while controlling healthcare costs. We also want to support and reinforce the population health goals expressed through our Quality Alignment Measure Set, or QAMS, so that a pharmacy vendor is working together with CalPERS health plans to improve overall quality for our members. I'll talk more about this when we get to our cost and quality guarantees. As a brief reminder, we conducted a nationwide market scan of pharmacy benefits vendors in the fall of 2024 and chose 16 entities with whom to enter discussions. These vendors included all three of the big pharmacy benefit managers, or PBMs, several mid-size and smaller PBMs, a coalition, and a health plan. In addition, CalPERS received proposals from each of the HMOs whose members currently receive pharmacy services through Optum during the 2026 rate development process to assess whether our members are better served by receiving pharmacy services carved out from their health care services. Through multiple detailed discussions with these vendors and health plans, we successfully narrowed the list to a few vendors with whom to enter best and final contract negotiations. We evaluated the final vendors in terms of 5 major areas: their financial offers, including pricing, discounts, rebates, and administrative fees, as well as the cost trend guarantee, clinical functions and flexibility, contract terms, particularly around transparency and auditing, the potential for disruption, and finally, each vendor's historical and current participation in the national marketplace. Our contract negotiations resulted in strong offers from final vendors, which have much better alignment with our goals and priorities than the current contract, including more favorable contract terms around auditing rights, transparency, and standard of care obligations, improved flexibility in formulary and utilization management, as well as potential carve-out of services, and significant money at risk for both cost trend and quality for both the basic and Medicare populations. We recommend that the board approve CalPERS entering into a contract with CVS Caremark for pharmacy benefit services based on their strong financial offer, particularly in the early years of the 5-year contract, the formulary that offer is predicated on, their willingness to accept the vast majority of our contractual terms, including financial accountability, and their comprehensive transition and implementation plan, inclusive of disruption mitigation strategies starting January 1st, 2026 to December 31st, 2030. I'll go into the details of why CVS is our recommendation in the following few slides. When considering the finalist vendors based on largely comparable formularies, CVS's financial terms reflect lower drug costs, larger rebates and discounts, and lower dispensing fees with slightly higher administrative costs. Based on our assumptions and projections, CVS's financial terms are stronger than the current PBM contract by over $600 million over the 5-year contract, on a total spend of over $10 billion. After a careful analysis of the potential disruption that could be caused by changing from the current formulary to CVS's proposed formulary, we estimate that about 5% of basic members and 15% of Medicare members would be required to switch to a different medication with this transition. All impacted members would be switched to a covered, equally effective alternative. Most of these formulary changes are not clinically significant and include brand to generic switches. To mitigate member disruption, CVS has proposed a comprehensive transition and implementation plan that we'll talk more about in a few minutes. Finally, CVS has agreed to contractual language that gives us far greater protections, transparency, audit rights, and other terms than we have had in past pharmacy benefit manager contracts, including terms that will hold them accountable to providing services in the best interest of CalPERS and our members. One of the groundbreaking elements we negotiated is CVS's agreement to strong cost trend guarantees, putting a total of $200 million at risk over 5 years for not meeting these cost guarantees. These guarantees are tied to cost trend targets of 6.5% or lower over the course of the contract. Additionally, CVS agreed to our proposed clinical performance guarantee regarding quality, which puts an additional $10 million at risk each year, $5 million for basic plans and $5 million for Medicare plans. The measures align with two of the quality alignment measure set measures controlling high blood pressure and diabetes care, both of which are measures that have concrete pharmacy interventions and allow for a pharmacy benefits manager to have a direct impact on health outcomes. In this way, the quality guarantee, which we have not seen in any other PBM contract, reinforces and supports the quality efforts across our health plans and PBM contract, and will reinforce and support collaboration in patient care coordination between CVS and our health plan carriers. All told, with the cost trend guarantee and quality guarantees, CVS is agreeing to put $250 million at risk over the course of the 5-year contract, meaning that CVS's bottom line is tied directly to our bottom line and our members' concern regarding affordability and better quality. I wanted to talk through some of the types of disruption, as it's a critical issue for our members. There is the disruption associated with having a new and different formulary that excludes different drugs and puts drugs into different tiers that can change copays. This is generally the type of disruption that members care about the most. And this type of disruption can occur with a new vendor, of course, but also if we remain with the same vendor. That's because there may be formulary changes that can result in member disruption due to different pricing under a new contract. In order to secure better pricing, a vendor may change their formulary, tiering, or both to get that pricing. There's also the disruption in the pharmacy network. In other words, the pharmacies at which our members get their medications filled, whether that be retail or mail order. Based on our analysis, if the board chooses to contract with CVS, about 95 to 99% of our members will have the ability to fill prescriptions at the same pharmacy they have been filling them, which is really good news. Finally, there can be disruption associated with a new member or customer service interface and set of staff who are new to CalPERS benefits. Any of these types of disruptions can be frustrating and inconvenient, but some of them, like exclusions of drugs that weren't previously excluded, are more impactful to members. We believe the formulary changes with CVS will put CalPERS and its members in a position to better manage costs over the long term. That doesn't mean we can't mitigate the impact to members in the short term, but over time, we believe that customizing CVS's formulary to best meet our members' needs is the best path forward. And remember, while certain medications may no longer be covered, they are being replaced with equally safe and effective alternatives. For CalPERS, our bottom line is that we will never compromise member safety, and we will always assure our members have access to alternative medications when that is clinically appropriate. Next, I'll briefly review the comprehensive transition and implementation plan and what it would look like with CVS. First and foremost, there will be extensive outreach to and communication with our members from both CalPERS and CVS. This will include mailings to members, an online tool to inform members about the vendor and any medication changes, as well as email, website, and webinar communications. CVS will also engage in targeted outreach specifically directed to members on specialty medications through mail and phone calls to ensure they have a smooth transition to a new vendor. There would be a CVS and CalPERS implementation team working together, led by an implementation manager, who will oversee all transition activities, including dedicated member or customer service staff that's available to CalPERS members 24/7, starting at the time of open enrollment in September. CVS has also provided us with staffing estimates, which are more than 4 times what would be the usual staffing numbers based on normal peak call volumes. So they seem prepared and have pragmatic staff expectations. CVS has also recognized the need to train dedicated staff on the CalPERS Pharmacy Benefits Program so that they are in the best position possible to assist our members starting in September. CalPERS would be hosting an in-person training for CVS staff in August to help educate them on the CalPERS Pharmacy Benefits Program, CalPERS culture, and our members. It's worth noting that CVS has transitioned over 100 clients from Optum to CVS in the past 3 years alone, so they have extensive experience in this area, including obtaining all relevant member data on prior authorization and open refills from our incumbent as part of a transition. There will also be clearly and repeatedly messaged prior use exception processes, as I mentioned earlier. In other words, allowing members who will need to switch medications to remain on that medication for a period of up to 90 days after January 1st. We have clearly communicated to CVS how paramount a smooth transition for our members is to CalPERS. Based on their transition plan thus far, they seem to have heard us, but we will continue to work closely with them to ensure this occurs. We view this new contract as a new beginning for our pharmacy benefits program. Over the past year, as we have researched, talked to hundreds of experts and other purchasers in this space, and kept our eyes wide open about the challenges in the pharmacy benefits industry. With this in mind, the team has worked really hard. We've engaged expert consultants and expert legal counsel to negotiate provisions to improve PBM accountability for cost and quality and transparency. I'm really proud of the work we did over the past year. This contract is unique. I hope it will be a model for other large and small purchasers to use. It creates guardrails for an industry where there were little to none before. We know, though, that the contract is only strong when we exercise our contractual rights to hold our PBM to account. So it's incumbent upon us to maintain constant oversight of how they're delivering on the terms in the contract. This will mean routine annual review and auditing of all pricing terms and rebates, as well as closely reviewing and overseeing the formulary. We intend to continue to enlist expert consultant help in these areas to ensure we're holding CVS fully accountable and that CalPERS and our members obtain the best possible financial and health outcomes over the 5-year period of the contract. Now we'll talk just a little bit about next steps. If you accept our recommendation, we will finalize the execution of the contract. Additionally, implementation, transition activities, and communication activities will begin immediately for a start date of January 1st, 2026. If I may have just a moment of personal privilege before we move to questions, I wanted to take a moment to recognize the team that worked on this effort. Each and every person was completely devoted to making sure we got the best outcome for our members. They were creative, supportive, and nimble, and often moved mountains that I sometimes didn't think could be moved. So thank you to all of the team, everybody here and who's watching. It's been a team effort, and we needed every single person to get it done. So thank you for that moment, and with that, I'll open it up to questions.
Thank you. I don't know if they're, some of them are probably just comments. So first, but I do want to say, I really like the contract. I really like that as we go. This is my second time for a big contract with you guys, and you seem to get better and better with each time. So I really do appreciate that. And you stole my thunder. We're going to have the info webinars, which I think are great. When we talk about the drugs, it might be different and going to things that are like, they will have the same clinical impact, but could be a different manufacturer, different drug or whatever. Is there actually going to be a list? And if there is, how soon will that be out? Because then I think it would give our members the opportunity to have conversations with their primary care providers, right? And so that could help decrease the chance of problems when we actually switch over. So I don't know if we're going to have that out, how far out in advance?
Yeah, so CVS would have a list of members who have an open prescription, or an open refill. So they will know who needs to be contacted and will be contacting them through letters to tell them your medication is now being switched to this medication as of January 1st, and give them some options, either to talk to their doctor, which is always a good idea, or to have a 90-day grandfather where they would get that prescription for 90 days after January 1st.
But that's only the open refill?
Yeah, so if you are on a medication, say for high blood pressure, lisinopril, and you are taking that and you've been taking that for a long time, CVS will have that data.
Oh, okay. The fact that you've taken it for a long time, not
Right,
that it's just
yes,
ready to be
yeah.
refilled. Okay. All right. And then like for me, I have one that it's a new prescription every month, which is crazy to me, but that's just what it is. And so would they have that information also?
They would
Okay.
have that information also.
Okay.
Yes.
And so we'd get, I guess what I'm wanting to maybe see, and I don't know if it's practical, of knowing like just having a list to look at, right? As opposed to waiting for the letter, because I'm not always very mail attentive. So the chances of it getting missed is big. I missed my initial Medicare card because, it was not visibly, it didn't say Medicare on it. So I shredded it before I realized that it was my Medicare card. So anyway, so
Yeah.
if there were a list that I could look at and say, oh, these are the drugs I'm taking, this is going to be different. Let me, I'm going in to see the doctor. Let me just have a preliminary conversation. That would be helpful, I think.
Yes, and that's a really good idea. And we do post the formulary that CVS will be using online. But yeah, sometimes having that whole formulary can be
Yeah,
overwhelming.
because that's not always helpful to me.
Right.
I've looked at
Yeah.
it and I come away more confused, so I've stopped looking at it. So yeah, but if they had the list, I could just go, oh, this is what I'm taking. This is what it's going to be. I wonder if this is okay. Let me talk to Dr. So-and-so.
Yeah, that's very good feedback. Thank you.
Okay. And then I just would like to know, because I know it happened, what were the lessons you've learned from our health plan change that you have moved forward into this?
Yeah, there have been a lot. We
I would
always talk
imagine.
about how we're a learning organization, and I think we learn a lot too in terms of what worked and what didn't. I think we learned a lot from the PPO transition, specifically our partners not necessarily knowing CalPERS culture and our members well enough before the transition, and sort of our members' needs on a day-to-day basis. And we always say that we know our members best. Obviously, we can always learn more, but and so that's why we're proposing to have that in-person training in August, because we did have an in-person training relatively recently with Blue Shield and Included Health, specifically around grievance and appeals and how that process flows. And that was incredibly valuable, not just because everybody learned about the process, but everybody learned about each other and CalPERS and our benefits and the culture. So that was really helpful.
Okay. And did you say, I don't know, because I might have blanked out, but are they going to come to the to a board meeting before January when it actually goes, just to like talk to us, look us in the eye?
They certainly can. We can certainly talk to them about that and,
That might be
and
helpful.
arrange that.
Okay. That's all I got. Thank you, though. You guys did an outstanding job.
Do I have any more questions from the board? Oh, sorry, Mr. Jose Luis, go ahead.
Yes, thank you. First of all, good morning, and thank you, Dr. Logan, for your comments. First of all, I am very impressed with CVS and this whole process, and I also want to thank your entire team. I think it's a team effort, and you've all gone 150% on it, and I really appreciate that. So my first question is regarding the financial and clinical performance guarantees. You mentioned that the $200 million at risk over a 5-year contract period with trend targets of 6.5% for both basic and Medicare. You said it's also very novel. It's not in other contracts. Can you elaborate on that a little bit, please?
Yeah, sure. So I noted that we talked to a lot of people, a lot of experts in the pharmacy industry, a lot of other states who purchase large PBM contracts, and no one we talked to had the same kind of guarantees that we did. With the first, the money at risk, the ability to have the trend guarantee of 6.5%. We all know that pharmacy costs are
Exactly.
rising exponentially over the past few years with very high cost medications used for chronic diseases now. So that's really changed the industry. So that trend is something that's novel. And then the quality guarantee.
Absolutely.
That was unheard of before we started.
And actually, that brings up to the next question about the quality alignments measurement sets. You had mentioned that it's going to be the hypertension and the diabetes. And how many times are we going to be receiving that information? Is it on a quarterly basis, on a monthly basis? How are we going to measure that?
Yeah, those measures are all of the quality alignment measures are reported annually. They're a retrospective look because they're a National Committee for Quality Assurance HEDIS measures, and so they're reported really over a year after the year stops, the measurement year stops. So unfortunately, it's not a real-time look at quality, but it does give us the ability to benchmark ourselves because we can compare ourselves across the nation.
And then with respect to those measurements in conjunction with the 250 million risk, we'll be able to figure out where we are in
Yes.
terms of our understanding. And then the last question I wanted to ask was with respect to transition and implementation. I noticed, first of all, very good with respect to all the outreach you'll be doing. But I wanted to know if you'll be also providing some of the material in Spanish or in other multiple lingual languages for our members who have more limited English and so forth. If that's something that will be on your horizon.
Yes, so we'll work closely with CVS on making sure that members have the information they need in the language that they feel most comfortable in communicating. And so we have we'll have the webinar, of course. Then we'll work with CVS specifically on the different member letters where they will have the translation services for the members should they be requested.
Excellent then. And thank you very much. Again, thank you so much for this work, and I appreciate all the work you've done. That's my questions.
And I do want to thank you guys for the work on this particular contract. I know it was very long and you got very creative about figuring out how we could keep best prices and get some really good negotiations done. So thank you again. I'm going to call on Mr. Palkey.
Thank you, Madam.
You're on.
Thank you, Madam President. I just want to clarify, because I think I heard it, and most of my questions were answered with Ms. Walker. But if a member has an issue with a certain prescription drug, whether it's usually it's like a brand name versus a generic, but if there's some sort of say an allergic reaction by that member, they can contact their doctor, and so it's not a true disruption, right?
Yes, exactly. So if there's a clinical reason that a member needs to stay on a medication that is now being excluded from the formulary, there are provisions to allow the member to continue on that medication. So their doctor can write an exception. They can talk to us. There's certain ways that they can continue with that medication. Yes, we would never, ever want a member to be on a medication that they're allergic to or that's not clinically appropriate to them.
Great. And if there's no objection, I'd like to make a motion to approve CVS for the next pharmacy benefits contract starting January 1st, 2026 through December 31st, 2030.
Madam President, I will be honored to second that motion.
Okay, great. I want to make sure that we don't have any public comment on the phone or in the room on this item before we take a vote? Nope. Nope.
Can
Oh.
I just ask one more question?
Sure, go ahead.
I think I asked this before, but I don't remember the answer. Is there any of our people that are not going to be impacted by this pharmacy change?
Yes, good question. So we have members in Kaiser and Blue Shield Basic Plan that are not impacted by this. We contract with them separately to have their pharmacy benefits carved into their medical.
Additionally, there's a couple of Medicare plans. So UHC's Group MA is not impacted by this because they have their own pharmacy benefits, as well as Sharp's Medicare Advantage plan.
Any other
Thank
questions?
you.
Okay. So the motion by Mr. Palkey, seconded by Mr. Rubalcava. Do we need a roll call vote? Oh, we do have, okay, so we need a roll call vote. Sorry.
David Miller. Aye. Deborah Gallegos.
This is me.
Michael DeToy.
Aye.
Frank Rufino.
Aye.
Orlando Ortega. Jose Luis Pacheco. Kevin Palkey.
Aye.
Ramon Rubalcaba.
Aye.
Yvonne Walker. Melissa Willette. Dr. Gail Willis.
All right, motion passes, so congratulations, you guys, for the great work. So then Don, go ahead.
If it's okay, just for a second, I wanted to also just acknowledge the incredible amount of work that the whole team put into this, but also the leadership that Rob and especially Julia exhibited. This was a heavy, heavy lift. I think we all know Julia as the thoughtful clinical leader of our programs. She's also a really good negotiator, and these are the best terms that you're going to see in any contract, PBM contract in the country. And that is thanks to their efforts here. It's innovative, it's protective, and it's going to serve us well. So thank you both for that.
Having good people in the right place. Thank you very much. So right now, we are going to move on to the approval of the 2026 Health Maintenance Organization and Preferred Provider Organization premiums. So that's our next action item. And with that, I'm going to turn it over to Rob Jarzembek, and you can present the premiums.
Okay, great. Good morning, Madam President and members of the board. Rob Jarzembek, CalPERS team member. This is an action item to approve the 2026 HMO and PPO plan premiums. Here's our agenda. We'll begin with the premiums and weighted averages, and they'll then refresh everyone on the key decisions we have for the basic plans this year. Finally, we'll seek your approval of the premiums and our recommendations. All premiums are now posted online as attachments to this agenda item, including the state and regional pricing. Let's start with the premiums and weighted averages for our basic plans. For the 2026 HMO premiums, the average increase is 6.5%. PPO premiums have an average increase of just over 12%. These numbers remain unchanged from what was presented in June. Here are the Medicare Advantage and Medicare supplemental premiums. These numbers also remain unchanged from what was presented last month. The MA average increase is just over 7%, and the MedSup average increase is 13 2/3%. This slide shows everything rolled up with the weighted average changes for each plan type and compares the 2026 increases to last year. CalPERS' overall premium increase is 8.21% and is a 2.6% improvement from last year. The next section to go over is our recommendations to the key decisions impacting two of our lower cost narrow network plans, Blue Shield's Trio and United Healthcare's Harmony Plan. As we discussed last month, TRIO's presence in Monterey County is having a significant impact on its premiums. If action isn't taken, we project that TRIO's premiums will increase to the Access Plus level in 2 to 3 years, effectively eliminating this low-cost option for our members. To address this issue, we recommend replacing TRIO with Access Plus in Monterey County. Access Plus is better poised to absorb the cost of Monterey members, as it can spread those costs out over a much larger population. By exiting Monterey, TRIO's statewide premium would improve as much as 6%, while Access Plus would experience a much smaller impact of less than a 1% increase to its premium. Similar to the TRIO situation, Harmony is facing a high premium increase for 2026. This is before including the cost of expanding to 4 additional Northern California counties. As we've discussed, Harmony expanded to new areas and its membership increased between 40 to 60% each year, which was higher than projected and has caused additional uncertainty and premium volatility. To help ensure the long-term viability of Harmony in our program, we recommend postponing Harmony's 4-county expansion for 1 year to allow their cost and membership to stabilize. To summarize our recommendations, we recommend that the board approve the proposed 2026 HMO and PPO plan premiums. We also recommend the board approve replacing TRIO with Access Plus in Monterey County and postponing UHC's Harmony expansion for 1 year. By approving the recommendation as written in the agenda item, your action will cover these 3 items. For next steps, once the board takes action, we will begin our communication activities in advance of open enrollment. This concludes the presentation, and we're happy to take any questions.
My, that was quick. Anybody have some questions on this? Okay. Okay, Mr. Palkey, go ahead.
So just to clarify some of the Access Plus versus TRIO.
Yep.
So Access Plus ideally opens up a network, right? And I've heard stories nationwide where individuals drive 6 hours to get the care they need. Does the Access Plus open up networks outside of Monterey for these individuals to go to if they're not?
So with the transition from TRIO to Access Plus, the network remains the same. And so the network that is in place for Blue Shield's TRIO product will be the exact same network that is used with Access Plus.
Okay.
In county.
In county.
So there are, counties are for health purposes, artificial barriers. What really matters is the distance from a hospital or a doctor's office. So Access Plus is a broader network than TRIO. So it is conceivable that there will be providers in surrounding counties that could be available through Access Plus as a broader network. The important thing for the purposes of the folks in Monterey County is that anybody that they are seeing through TRIO, they will be able to see through Access Plus.
Thank you.
Okay. Mr. Rubikava, it looked like it was Don's microphone, sorry.
No, I just want to thank Rob and the team for another great year. A great renewal process. It's always been very challenging, but I'm very pleased that we were able to see some drops, some decrease in the HMO rates. Medicare has its own challenges. Thank you.
Thank you. And I will say I think that you guys also were very good at trying to figure out how to access or make healthcare accessible to our rural folks. I hear a lot from our employees at the state that, work all over the state of California, that it's tough for them to get healthcare. So we really appreciate, forging ahead with Monterey and other places and the EPOs that you've created also. So thank you very much. With that, I will call on Mr. Palkey again.
Thank you. So I would like to make a motion to approve the 2026 Health Maintenance Organization and Preferred Provider Organization premiums as recommended.
All right.
I'll be happy to second.
All right, so it's been, the motion's been made by Mr. Palkey, it's been seconded by Mr. Rubalcava, and I'm gonna do another roll call vote to have it on the record. Oh, I'm sorry, I have two people that need to, comment on this, Mr. Jelensik in the room, Mr. Woodson on the phone. Thank you.
Good morning. J.J. Jelensik, Health Director, RPEA. The rates are too high, but everybody knows that. It's a fact of life. Rates increasing at 3 times the rate of inflation is not something to brag about. Most of my members are in Medicare, so they're not subject to the board's risk adjustment policy. But I will point out that the board adjusts risk based on cost and not the health characteristics of the insured. You subsidize those who pick high cost, lower efficiency plans, and you penalize those who pick low cost, efficient plans. The insurers certainly understand the subsidies, and I'm sure they game it to maximize their profits. How do you calculate the risk scores and the risk adjustments? You start with costs. From there, who knows? The board policy is that the public is better off not knowing how you come to those numbers than it would be to know. I don't know who you're protecting, but when you say the public should not know what we are doing, that is certainly not conducting the public's business in public. Thank you.
All right, thank you. Our next commenter is on the phone line, as I understand it.
Yes, President Taylor, Larry Woodson is on the line for public comment. Go ahead, Mr. Woodson.
Yes, can you hear me okay there?
Yes, we can.
Okay. Well, good morning, Larry Woodson, California State Retirees. Madam Chair, thank you for the opportunity to comment. I've got to say this is a first. No rates of any company are lowered from the preliminary rates. So the comments I gave in June, I would ditto today. Some are just too high. I'm going to focus on United Health again, which moved from 4th to 3rd in the Fortune 500 with revenues of $400 billion and profits of over $15 billion. They should not be increasing rates at close to double digits. Perhaps I should be more cautious about publicly criticizing United Health after reading a July 12th New York Times article titled United Health's Campaign to Quiet Critics. It details United Health's new strategy to address bad press and other public exposés about United Health practices, which have caused harm to those it serves. They've employed a law firm, Clear Lock, as their defamation counsel, and began to sue media like The Guardian, Amazon Prime Video, and others for defamation. I encourage you to read that article. I want to address PE acquisition of healthcare in particular and how that can impact rates and much more. I did read the preliminary return for yesterday. The returns are quite good. PE was surprisingly high, though 2.5% lower than public equity. But many of us have continuing concerns about PE managers' self-valuation and its accuracy. I reported 5 or 6 years ago to this board a study which concluded that many PE GPs overvalue their funds when reporting, and the study actually found a couple that they felt had overinflated by up to 100%. So the true value of these illiquid investments can only be determined upon liquidation. But more importantly, we read again and again the deplorable effects PE acquisitions are having on healthcare. And in that vein, I applaud CalPERS' close look at SB 351 by Senator Cabaldon and hope that after Danny Brown's presentation to you tomorrow, you'll unanimously endorse it. It, of course, falls short of banning PE acquisitions of healthcare, but at least it puts some significant restrictions on PE in that situation. PSR has endorsed it, and our president, Joe Reynoso, has been in touch with the author. Lastly, I'm reading a book that I highly recommend to board members, investment staff, and health team staff called Bad Company, subtitled Private Equity and the Death of the American Dream by Megan Greenwell. And so far, it fully deserves the praise on the book jacket that it's a timely work of singular reportage and a damning indictment of the PPE industry told through the stories of 4 American workers whose lives and communities were upended by the ruinous effects of PE takeover.
Larry,
He also
you're
gives
out of
another
time.
example. This is my last sentence. CalPERS gets some coverage as well, and if you read this book, you may not be so enthusiastic to invest billions of our pension funds in PE. Thank you.
Thank you, Mr. Woodson. I don't think we have any additional comments. All right, so then let's go ahead and take a roll call vote on the motion.
David Miller.
Aye.
Deborah Gallegos. Michael DeToy.
Aye.
Frank Rufino.
Aye.
Lorena Ortega. Jose Luis Pacheco. Kevin Pauke. Ramon Rubalcaba. Yvonne Walker. Melissa Willett. Dr. Gail Willis.
All right, the motion passes unanimously, so thank you everyone for that presentation as well. So now, you're just famous today, Rob, aren't you?
Not the same.
We're moving on to state employer annuitant contribution formulas and amounts and association plan premiums. So we appreciate looking at this and having this published. So take it away.
Okay, thank you again. Good morning, everyone again. This is an information item regarding the 2026 state employer annuitant contribution formulas and amounts and association plan premiums. We will look at the state employer annuitant formulas and their corresponding employer health contributions, as well as the association plans premiums for next year. The attachments are posted online for this presentation as well. On this slide, we show the state employer annuitant types and their corresponding contribution formulas. In general, there are 2 groups of annuitants: basic annuitants, who are enrolled in the CalPERS Basic Health Plan, and Medicare annuitants, who are enrolled in the CalPERS Medicare Plan. These 2 groups fall under different state contribution formulas based on the member's date of hire and bargaining unit. The 190 formula includes basic and Medicare annuitants hired prior to 2016 or 2017 and includes CSU members. This contribution amount is determined by CalPERS. The employer contribution for this formula includes 100% of the weighted average basic premium for subscribers and 90% for dependents. The 80-80 basic formula is for active annuitants hired on or after January 1st, 2016 or 2017. This formula excludes CSU members and is calculated by CalHR. The employer contribution for this formula is 80% of the weighted average basic premium for subscribers, as well as 80% for dependents. Lastly, the 80-80 Medicare formula is for state Medicare annuitants hired on or after January 1st, 2016 or 2017, and also excludes CSU members. The contribution amount for the Medicare formula is calculated by CalPERS. The employer contribution here is 80% of the weighted average Medicare premium for subscribers and 80% for dependents as well. On this slide, we can see the tiers for the employer health contributions for all 3 formulas discussed on the prior slide. The tiers are single, 2-party, and family. Now we'll briefly touch on the association plans. As a reminder, CalPERS does not administer the association plans. The associations are responsible for ensuring that their premiums and benefit changes are appropriate and that their reserves are adequate. For the 2026 plan year, the California Correctional Peace Officers Association, or CCPOA, is changing its basic health plan from an HMO to an exclusive provider organization, or EPO. This was done to expand member access to care, as the HMO plan did not cover all of California. There are no changes to the CCPOA Medicare plan, as it remains a PPO plan. The other two associations did not have any changes for next year. Here are the association plan's weighted average premium changes for 2026. The basic plans have just over 7.25% increase from last year, and the Medicare plans have a 9.2% increase. The next steps here are to communicate the association plan premiums to our members prior to an open enrollment. Open enrollment starts on September 15th and ends on October 10th. The effective date for the association plan premiums, as well as the employer contribution amounts, is of course January 1st, 2026. This concludes the presentation, and I'm happy to take any questions.
Does the board have any questions on this? Heard a voice. Okay. So no, it looks like we're good. So then, if that's the case, this was an information only item. We will move. I hope you guys can hear me. I keep backing away from the mic. We will move on to the clinical update, focus on chronic disease and behavioral health board education. The second half of the presentation will discuss efforts to improve behavioral health access and treatment for our members. And with Dr. Logan is joined by Dr. Lisa Albers, medical program consultant for our clinical policy and programs team. And when you guys have a minute. Anytime you guys are ready and settled, go ahead and start. You go ahead and start anytime you're ready.
Thank you. Okay, thank you. Good morning, President Taylor and members of the board. Julia Logan, Chief Clinical Director, CalPERS team member. I am joined today by my colleague, Dr. Lisa Albers, our Director of Clinical Policy and Programs. We're also happy to introduce Dr. Christina Almeida, who joined CalPERS last October from the Department of Healthcare Services as our Population Health Medical Director. Lisa and I will be talking with you today on various topics, and Christina, whose work contributed to these slides, will be here today to help answer any questions at the end. We're excited to talk with you all again on clinical topics that impact our members and their health care. First, based on board direction back in March, we'll provide an overview and some current data on the impact of chronic conditions on our members, which will hopefully provide a useful background for our second topic, which is our population health approach. Here we will provide an update on the clinical services provided by our new population health management vendor, Included Health, that has been serving our PPO members since January of this year. Last, I'll share some updated information on the important work to improve access to and the quality of behavioral health services for our members. I'll turn it over to Lisa to get started.
Thanks, Julia. Hello, President Taylor and members of the board. It's nice to be here again. We always like to set the stage with this next graphic, there we go, because it's what informs the development of all of our health initiatives, including our population health management approach. At CalPERS, as you know, our strategic goal for health is to provide exceptional care for all our members. This means that our members are at the center of everything we do and every decision that we make. And our goal is that all our members have access to equitable, high quality, and affordable health care. So first, we'll dive into some data around chronic disease in our CalPERS members. So this first colorful slide shows the year-over-year prevalence rates for the most common chronic medical conditions for the total CalPERS population from 2022 through 2024. This includes our basic and our Medicare members. And prevalence, just as a reminder, is the proportion of any population that has a given condition or diagnosis in a particular time period. So to get you oriented on the slide, 2002 is on the left-hand side, followed by 2023 in the center, and 2024 on the right. That's our most recent data for calendar year 2024. Each year has our 5 most common chronic conditions represented by a different color, which you can see across the top of the slide. Those most common conditions are hypertension or high blood pressure, diabetes, osteoporosis and osteoarthritis, which, while different conditions, were grouped together in the data due to their common co-occurrences in older adults, high cholesterol, and cancer, with hypertension and diabetes being the top 2. So rates are generally stable over time. You may notice a small 2 to 3% decrease in the rates for hypertension and diabetes in 2024 versus the earlier years, but we believe that's likely due to a data lag and adjustments or changes to claims data based on when the data was pulled in mid to late spring, and we expect that those rates will go up somewhat for 2024 overall as the adjustments come through in the claims data. Next slide. So on this slide, we compare disease prevalence for the same chronic conditions for the basic versus the Medicare population. So the Medicare population is represented by the gray bars and the basic population by the teal or the blue bars. Some notable findings from this graph include that nearly 1 in 4 of our Medicare enrollees have high blood pressure or hypertension. There is, not surprisingly, a higher prevalence overall for all 5 chronic conditions in our Medicare members when compared to our basic. There's a low overall prevalence of cancer in the basic population when you compare it to the Medicare population. And all of these findings are consistent with the increasing prevalence of most chronic diseases as we age. Next slide. Here we provide a comparison of chronic disease in the PPO versus the HMO population, with the PPO now being represented by the gray bars and the HMO by the blue or teal bars. Some notable findings on this slide are that, again, hypertension is the most prevalent chronic condition for both populations. The second most prevalent condition was different for the 2 groups, with it being that osteoarthritis and osteoporosis grouping for the PPO and diabetes for the HMO population. This may in part be due to the fact that our PPO population does tend to skew a little bit older than our HMO population. There is also a higher prevalence overall in the PPO population for all 5 chronic conditions when compared to the HMO, which is consistent with what we know about our PPO plans. And then based on data that's not shown in the slide, all 5 of the conditions have a higher prevalence in our platinum plan versus the gold plan in the PPO, which is also consistent with what we know about enrollments in the 2 plans. On the next slide, which is a bit crowded, sorry about that, we compare chronic condition prevalence rates for the total population broken down by age groups. As expected, we see a much higher prevalence for all conditions in adults and seniors than adolescents and children, certainly. Some other observations from this graph are that hypertension is most commonly seen in adults and seniors, but diabetes and high cholesterol are the most common chronic conditions for adolescents and children, although the incidence in those age groups is still very low, of course. For seniors, the second most common chronic condition is osteoarthritis, and osteoporosis, while for adults it's diabetes, and that mirrors the same trends that we saw in the previous comparisons of the HMO versus the PPO and Medicare versus basic. On this next slide, we're going to switch gears a little bit and talk about the cost impacts of chronic diseases. And I'll start with what is a useful way to represent where our healthcare spending goes. And that's that healthcare spend pyramid that you see on the left side of the slide. Captured in the pyramid, you can see 4 levels or tiers of annual medical spend. That includes total medical and pharmacy spend. It's 0 to 1,000 in the lowest tier, then 1,000 to 25,000, et cetera, with the top tier being 100,000 plus. Also on that pyramid, you'll see the percentage of our members who fall into each spend category. On the right side of the slide is the percentage that each category of spend contributes to our overall healthcare spend for 2024. So most significantly, the top 5% of members with the highest amounts of annual spend, that's those who are in the top 2 tiers of the pyramid, they account for 62% of our total medical spend for 2024. So when you add those top 2 tiers, the 35 and the 27%. While the remaining 95% of members, those in the lowest tier, 2 tiers, make up a much smaller percentage at only 38%. And if you look at the lowest tier, that's 44 to 45% of our members, they have very little annual spend at less than 1,000 per member per year. So I think what this really demonstrates is how critical it is to have health benefits rooted in high quality primary care in order to help prevent the progression to more complex chronic illnesses. It also illustrates why it's critical to have strong chronic disease care management resources to help members who do find themselves with more complex conditions get the best care possible to prevent further progression of disease and complications leading to emergency room visits and hospitalizations. And particularly for those members in sort of that second tier from the top, where those with expensive, complex chronic conditions may be more likely to fall. This next slide looks at the cost impacts specific to the 5 chronic conditions that we've been focusing on in our earlier slides. And here we're comparing the cost of care for the CalPERS total population, again, that's going to be basic and Medicare combined, for the 5 most common chronic conditions from 2022 to 2024. The different color bars each represent a different year. And so when you look at the most costly to the least costly conditions, it starts with cancer at $1.64 billion, followed by diabetes, then that combination of osteoporosis and osteoarthritis, hypertension, and high cholesterol. You may recall this is not the same order as we saw with the prevalence when we looked at the prevalence slide. Of note, what we see here is that the cost of cancer by far outpaces costs for any other condition and has been steadily increasing year over year. And that's not surprising given the cost of many of the new chemotherapies and targeted gene therapies. You may also notice there was a moderate reduction, or I'd say mild reduction in spending for diabetes and hypertension from 2023 to 2024. However, we think that part of this difference is due to that claims lag that I mentioned earlier, and that it's the claims adjustments come through and catch up in the data, that spending gap, or sorry, that difference in spending will narrow. So now that you know a little bit more about how common many of these conditions are amongst our members and how much of our overall healthcare spend is going towards their care, we wanted to provide an additional spotlight on the costs of care for one of these common conditions, namely diabetes. So to remind you, diabetes is the 2nd most prevalent chronic condition in the CalPERS population, and it accounts for $617 million of our spend in 2024. Those costs are for all of medical and pharmacy care related to diabetes. So one of the primary reasons that diabetes is so costly is due to the newer medications to treat diabetes, namely the GLP-1s that we're also familiar with. While GLP-1s have been available to treat diabetes for almost 20 years now, it's the more recent addition of the very effective GLP-1s, the Ozempic or the Mounjaro, that are really driving up the costs. These newer GLP-1s, they lower something called hemoglobin A1C more effectively than older versions of the drugs, indicating better control of glucose levels and better management of diabetes overall. And they have the added benefit of improving cardiovascular outcomes for many patients with diabetes. The advantage these drugs offer have been reflected in recent updates and clinical guidelines that preferentially recommend the use of GLP-1s for many patients. But as we all know, they are quite expensive. So when drilling down into the pharmacy spend data for our members covered under Optum, which is about 600,000 members, as you heard earlier, if you look at the right side of the slide, you can see that diabetes accounts for 17 to 19% of our total pharmacy spend. The most expensive drug class for the care of diabetes are the GLP-1s, not surprisingly, with Ozempic at the top of the list. So I think this again just reiterates how critical it is that benefits such as high quality primary care and chronic disease management are in light of these expensive and prevalent chronic illnesses. So now we'll transition to talking about some of the strategies that our health plans are using to manage these members. One of the ways we help manage members through their chronic disease is through population health management. Our goals with our population health approach are to improve the physical and behavioral health outcomes for our members through a patient-centered and data-driven approach to whole person care. And then the next slide will provide a few examples of what our health plans are doing to support members with chronic or complex conditions through their own population health programs. So first, we'll talk about our HMOs. We have numerous contract requirements in our HMO contracts around population health management. These include that the plans must provide evidence-based disease management programs that incorporate health education interventions and engage members in their own care for conditions such as diabetes or high blood pressure, asthma, or congestive heart failure. We also require complex case management programs in accordance with the National Committee for Quality Assurance's accreditation standards for plan members who are having complex acute or chronic illnesses or injury to better support them in navigating their care. We also require a diabetes prevention program, a type of program certified by the Centers for Disease Control and Prevention that helps to identify members at high risk for developing diabetes and that utilizes lifestyle-based interventions to decrease that risk. So this slide highlights two of our health plans population health activities. The first on the left of the slide, this program addresses members' needs during transitions between different levels of care, such as when a member is being discharged from the hospital to home, or from a nursing facility to home, or from hospital to nursing facility. These are critical times to prevent readmissions or additional emergency room visits. So in this program, a care manager initiates early discharge planning with an assessment of home safety, post-surgical needs, caregiver availability, transportation needs, medications, durable medical equipment. And having all of this in place helps to ensure that the member has the resources they need to continue to improve and to stay in their home or to stay at that lower level of care. The second program on the right utilizes an interdisciplinary team to address members' physical, behavioral, and psychosocial needs and to provide care navigation and care coordination for members with complex or conditions or advanced disease. Both programs use data to identify members who might potentially benefit. They have licensed clinical staff to engage with members, and they use these interdisciplinary teams of doctors, nurses, pharmacists, social workers, who all work together to develop the best treatment plan and help navigate the members' care. So as you are all very well aware, in our new PPO contracts, we wanted to mirror the same population health management requirements to which we hold our HMO plans. To facilitate this work for a PPO network, we contracted with a population health management vendor, Included Health, as you know, to be the front door for our PPO basic members. In addition to providing member services, Included is also contracted for care navigation services, care and case management services, especially for our most complex members, and virtual primary care, urgent care, and behavioral health services to supplement access to our PPO's network. In the next several slides, we'll share some early utilization and engagement data since the PPO contract began on January 1st. Over time, we look forward to coming back and sharing more clinical process and outcome results, interim measurements of our outcomes around the total cost of care and quality measure set, and also information on how we're evaluating the program. So this first slide here summarizes the clinical services provided by Included Health starting January 1 through April 30th. The most frequently used category of services to this point is provider referrals. It's actually composed of two distinct services, provider match and concierge referral. The volume is largely driven by provider match, which is a self-service app on the Included Health, a self-service function on the Included Health phone app that delivers a list of network providers in whatever specialty that the member is searching for or requests. Concierge referral is a live, similar service where a member calls and talks to an Included Health representative who can find them that provider and then make them an appointment as well. It makes sense that this has been the most heavily utilized service to date, given the transition and the fact that some members needed to switch providers. The next most frequently used service is live clinical support, which is also actually two distinct services, the nurse triage line and treatment decision support. These are both nurse-run lines that help members either talk through a diagnosis or treatment option, or they can help members decide the level of care that they need, such as urgent versus routine primary care. Next, care and case management and maternity programs follow, and these are targeted to engage specific high opportunity members, which I'll talk about more in just a few slides. The remaining two services on the slide that you see, one is expert medical opinion. This is a unique included health service that provides an expert specialist consult for members who are interested in a second opinion on their diagnosis or treatment plan, such as a member who has a new cancer diagnosis. And then Healthy Days Support is another unique service to Included, in which, based on members' responses to standard survey questions, members who endorse a low self-reported health status, and that may be physical health or it could be behavioral health, they are outreached to by Included Health clinical staff who try and connect them with services to better support them. This slide summarizes the utilization of supplemental virtual health services with Included Health providers, again from January 1st through the end of April of this year. The virtual primary care and behavioral health services are intended as an important enhancement to the suite of benefits that are provided by our PPO and to provide additional access when needed. So they're really there to support in-person care, not to replace it. The largest proportion of virtual visits so far have been for urgent care, which are labeled on-demand medical visits in the slide. And based on diagnosis data, they were largely for seasonal upper respiratory infections, which makes sense given the time of year that the data reflects. Then these are followed by non-physician mental health therapy visits, and then by primary care visits, which are actually labeled scheduled medical visits on the slide, and finally by psychiatry visits. Earlier, I mentioned high opportunity members and Included Health's care and case management program. So I wanted to talk more about who those members are and how Included is supporting them. On this slide here, we are illustrating how Included Health identifies the PPO members that may need more intensive care management. These members are identified in a number of ways. It can be through internal referral from other Included Health services, like that nurse triage line, for example. It can be from claims information, and it could be a referral from our TPA Blue Shield or a provider. Once identified, members receive targeted outreach via telephone with multiple attempts to see if they'd like to enroll in care management. So the members who are identified for this particular service are those who are depicted on the right-hand side of the slide. So they fall into generally 6 categories. Members whose medical spend is greater than $50,000 over the time period of 1 year. Members who are pregnant. Those with a history of spine surgery or at risk for upcoming spine surgery. Members with a recent hospitalization. Members with a new complex chronic disease diagnosis, such as multiple sclerosis, for instance, or finally, members with a chronic condition and 2 or more recent emergency room visits or hospitalizations. On this next slide, this summarizes the high opportunity care and case management population that's been identified through the end of April of this year, and it's about 15,300 unique individuals. That number does represent individual members. However, you might notice that the numbers just above the 6 bars to the left of the total bar add up to more than 15,300. And that's due to the fact that some of these members may fall into multiple of these high opportunity buckets. Members who have an annual spend over $50,000 and those at risk for spine surgery are the most frequently identified flags for care and case management outreach. Now note that these are the members who have been identified, but many have not yet been engaged and enrolled into care plans. So on this next slide, we're going to look at how many members have engaged at each step of the care management process. And that's represented here by this funnel on the left-hand side. This describes the current progress on care management activities as of the end of April. So of the 15,300 or so high opportunity members that have been identified, 86% have received an outreach attempt from Included, which is terrific. Now the challenge remains in the next step along this funnel or journey, where only about 19% of those outreached have been successfully contacted. On the slide, this is delineated by the term reached, and that means members have actually responded to an outbound communication from Included Health and engaged in conversation with one of their clinical staff. Now, we think that the targeted outreach and general marketing campaigns that Included Health has just finished will help boost this engagement. The final step also presents an ongoing challenge, as of those that were successfully outreached so far, only 22% have enrolled in a care plan. Now, while not all identified members will necessarily need or want a long-term care management program, we do hope to see increases in this last step of the engagement process. But it's important to remember that this represents only the first 4 months of Included Health's engagement with our members, so it's still early days, and we expect that engagement will increase as members get more familiar with Included. Additionally, Included is also working to understand our members better and the potential barriers to engagement to care. So they've proposed conducting focus groups and a survey to help tailor their outreach activities and to improve the services that they provide to our population. So with that, I'll hand it over to Julia to give an update on behavioral health, and then we look forward to your questions. Thank you.
Thank you so much, Lisa. Next, we'd like to switch gears and focus on one of the areas that's key to our population health strategy and our commitment to our members, behavioral health. As we've done in past Offsite presentations, we'll go through a summary of prevalence trends for common behavioral health conditions, provide an update on our timely access study, and key findings from our annual health plan member survey, and finally provide an update on the new and ongoing initiatives for our behavioral health strategy. On this slide, we see the year-over-year trend for anxiety, depression, and substance use disorders from 2020 to 2024 for the CalPERS basic and Medicare populations. Rates for anxiety and depression are higher in the basic population than Medicare, and both diagnoses have experienced a modest and steady increase over time. Particularly for our basic members, the prevalence rates of anxiety and depression are up there with other chronic conditions like high cholesterol and osteoarthritis, which is why we continue to prioritize quality and access for members with these diagnoses. The rates for substance use are similar between populations and have remained stable over time. We also looked in more detail into behavioral health conditions for basic and Medicare populations as part of our data review by different age groups and for more detailed diagnosis types. Of note, we find that adolescents, out of all of the subgroups analyzed, have the highest prevalence rates for anxiety and depression, although the rates for the entire basic population are starting to catch up. It's not surprising and consistent with data we've previously presented and highlights the importance of continued efforts on improving access to and quality of behavioral health services for teens in particular. We find a slightly higher prevalence of psychosis diagnosis in the Medicare versus basic population, which may be a result of the fact that having this type of diagnosis qualifies one for a disability and makes one Medicare eligible at an earlier age. When substance use disorders are broken out into specific substances, we find that alcohol use disorder is most frequently found, followed by nicotine and opioids, although these rates are overall very low, which is consistent with national trends. Now that we've provided some background on the impact of behavioral health conditions on our CalPERS population, we wanted to step back and speak a bit on our current overall strategy on improving behavioral health for our members, which includes providing advocacy. And this is advocacy for our members at the individual level through routine monitoring of our appeals and grievances, using our contract as a lever to monitor and improve quality in behavioral health, member education on behavioral health benefits and how to access them, but also advocacy at the state and federal level through policy and collaboration with other stakeholders. In terms of access, working to improve and understand gaps in access to behavioral health through our timely access survey, and again, working with other stakeholders to ensure our members have access in all settings through primary care, outpatient behavioral health, and if they need inpatient services as well. And of course, working in alignment with our statewide and federal partners, we're working on several different initiatives to improve on behavioral health access and quality. As you're aware, every year we conduct our annual health plan member survey where we ask a sample of our members about their experiences with their health plan and their health care, including primary care, specialty care, virtual care, and behavioral health services. We use this information to identify areas needed for improvement or to make necessary changes to our benefit designs. Our 2025 results, which reflect services that members received in 2024, show that most members who received counseling and treatment felt that they were helped by their care. However, this number has been declining since 2021, when it was 87%, to the most recent results in 2024, when it was 76%. While we know that fewer members surveyed feel that their counseling and treatment helped, we continue to try and understand why it didn't help. Almost 3/4 of our members surveyed continued to report that their behavioral health access is stable in 2024, meaning members were able to get in as soon as they wanted, and in fact, that number has increased somewhat over the past 2 years. Additionally, more members are reporting that they're able to get care right away than they did last year. Finally, we do see an increase in the percentage of members using virtual or telehealth services for behavioral health, up to 10% in 2024, which is consistent with trends in how people are utilizing virtual care. As I mentioned in my behavioral health update last year, we've engaged UC researchers to conduct a timely access survey for outpatient behavioral health services, meaning therapy appointments with non-physician providers like social workers, psychologists, marriage and family therapists, etc., using a secret shopper survey method. The secret shopper method uses anonymous simulated interactions, like phone calls, with providers and provider offices to check appointment availability. In other words, simulated patients call provider offices to see how soon an appointment is available. The intent of the survey is to evaluate behavioral health access and provider availability for our CalPERS HMO and PPO basic populations, to identify potential barriers or challenges that may impede members from accessing behavioral health services. UC staff has completed these simulated calls for a statistically significant sample of providers across all our HMO plans. They will start calls for the PPO plans this month. Next steps are to do an analysis of our CalPERS health plan provider directories for accuracy, as this has been identified as an issue in securing appointments in a timely manner. We expect to have results to share with you in early 2026. As we move towards 2026, we want to highlight several initiatives that make up the multi-prong approach we are taking with our behavioral health strategy of advocacy, access, and alignment. Given its importance to our CalPERS members, we want to continue to support both our health plan activities to improve their behavioral health services and work at the system level to align with other payers like DHCS and Covered California and other statewide partners. We participate with other payer partners on the methodology and targets for behavioral health spending with the Office of Healthcare Affordability. We've made progress on measuring spend and are deliberating on appropriate targets to ensure resources are allocated effectively to meet our members' needs. We continue to support CalPERS health plans in their efforts to improve behavioral health access and quality. This year, Blue Shield has made the decision to bring their services back into their network rather than outsourcing to Magellan, with the goals of improving oversight of member access and utilization, decreasing care fragmentation, and standardizing measurement of quality and member experience. We are already working with them to minimize member disruption when this change goes into effect in January. We support our plan's efforts in the California Quality Collaborative's Behavioral Health Integration Initiative and work collaboratively with the National Committee for Quality Assurance to promote and encourage behavioral health integration through policy and advocacy. We also continue to push forward on work to improve access and quality in our behavioral health strategic measures and 2026 contract amendments that are aligned with our payer partners and our behavioral health measures in our quality alignment measure set. We work at the national level as part of a National Quality Forum Payer Advisory Council to identify measure sets for certain episodes of care like cardiovascular disease that include an important behavioral health component. And last, we continue to use the alignment work with the Department of Healthcare Services in Covered California to make improvements in our contracts to ensure our members have access to high-quality behavioral health care. That concludes our presentation. We really thank you for your interest and your advocacy on behalf of our members, and we're happy to answer any questions.
So thank you very much for the presentation. Excellent presentation. So as we get into the behavioral health, I think I was the most hopeful at the end here where you're talking about utilizing the secret shopper, et cetera, and including Kaiser and Blue Shield. And then also Blue Shield is bringing the behavioral health back in-house. I don't know what that means. I think the choices are still pretty hard, but one of the things you run into when you're looking for a therapist is this long list they give you, right? And then over half of them don't even apply to what you're looking for. You know, they might be for children or couples or family, but they're not just for a single person's therapy, right? So that'll probably come out in the secret shopper. But the other thing I think that's interesting is that my husband had a therapist, and when I switched to Blue Shield, she wouldn't take Blue Shield because of the Magellan issue, and they would underpay her and were very difficult to get payments from. So yeah, so he almost lost that therapist. I think we got her for 1 more year on a special contract. But those kinds of things are, you know, you want continuity of care for a therapist especially, and that becomes problematic. So I'm excited to see where that goes as well. But thank you very much for this, and I appreciate it. And it looks like Mr. Roop.
Thank you, Madam President. Thank you for the presentation. It was very, very interesting. Thank you for the presentation. It was very informative and important. I want to go back to the disease prevalence section before I go to behavioral health. On page number 7, when you compare the disease prevalence between PPO and HMO, on some, for example, the high blood pressure and others, high cholesterol, there's a distinct difference between the PPO and HMO. And I know we have a program to integrate primary care and care management into our PPO, but is this also a reflection of the system change differences, like where there's less of a primary care approach and co-pays vary, the deductions vary, or is it because PPO members tend to choose specialists who may not be focused on the whole body, and they might be as focused on whatever the specialty is? I was wondering if there's more detail to this, or you can give some comment on why we see the numbers we see. Thank you.
Excellent question, and I'll dive in, and then please, Christina or Julia, say what I didn't say and forgot to say. I think it's a really astute observation. First of all, we do know that our members in the PPO, as I mentioned, tend to skew a little bit older and sometimes to be a little bit sicker. And one of the reasons that they choose the PPO is because they can go straight to a specialist and don't necessarily need that primary care referral. On the other hand, the downside of that is that they may not be as engaged with their primary care. So I think you sort of hit the nail on the head. And that's one of the reasons that we we're so deliberate in our contracting with Blue Shield and Included Health is because we very much want to promote primary care and preventative care for this population in the same way that we do for the HMOs, and to try and decrease some of that difference in the disease prevalence if possible. And in fact, we're currently working on a primary care strategy amongst CalPERS, Blue Shield, and Included Health that we can all work on together and be aligned on. So just sort of a high-level response to say, I think your observation is correct. I think there are a number of reasons behind it, and we are working to try and make sure that the gaps between the disease prevalences narrows in the two populations.
I agree. And just to also add that, and I know that behavioral health isn't on this slide, but, and you mentioned it also, that behavioral health is really inextricably linked with all of these chronic conditions. And that's why we are focused on behavioral health integration into primary care, as Lisa mentioned, that it's so important to have that happen at the primary care level. So that primary care clinician and the patient can work together on all of those issues at the same time, because nobody has just high blood pressure and without other things, and then you don't sort of have that in isolation.
Thank you, and thank you for including the integration of behavioral health in your answer, because the comorbidities, I mean, like depression, for example, if you have a chronic disease, it exacerbates your depression. I can see how it works, and I'm glad we're trying to screen for that, and I have a question on that later on. The next question is on the spotlight on cost for diabetes on page chart 11. There's two diagrams, two charts. The one on the right has a asterisk, meaning it's only for Optum RX pharmacy benefits. But the one on the left, does that include overall? It says overall, so that includes Kaiser, anybody else, Sharp? Okay, just want to
Yes,
make sure I read that correct.
That's 617 million for the total cost. That's for all of our members, basic and Medicare, and all of our plans.
Great. And then on the included health clinic services, I noticed that one of the programs, which is very good, is a maternity program. And I've always had an interest in, we have a very rich, I think we were talking during lunch, we have a very rich benefit program, benefit design that includes prenatal care. And now I actually added the other service that I pronounce it Duba? Dula, okay. So I'm glad people are taking advantage of it, but I just want to, do we see, we've had, well, it's not listed on as the disease prevalence, but do we have an issue or a problem with problem pregnancies? And are we impacting that through this program at all?
A great question. I think that everyone has patients who are high risk for maternity and have complex pregnancies that need to be addressed, and we are no exception there. And Included Health, they outreach to all of our pregnant members, which is outstanding. And so they provide any pregnant member with the option of enrolling in the maternity program, whether they are low or high risk, but they make a concerted effort with those who have been identified as particularly high risk. So yes, those members are definitely being targeted and outreached to. And you mentioned doulas. We have doulas that are now offered through both Blue Shield and Included Health for our members who are pregnant, which is also outstanding, whether they're low or high risk, to support them through their pregnancy and postpartum period.
Very good, thank you. I'll move down to behavioral health. On the health plan member survey, there's one of the data points is that screening for mental health by care team has increased, which is good. But do we know how much has increased? And outside of the member survey, is there, I know we have it in our contract with HMO to focus on that. Do we monitor that separately through the contract? And what can we say? What has been the success rate? How is it increasing? What have been the outcomes?
Yeah, so as part of our contract, I believe when we renewed the HMO contracts in 2024, we added a provision that the health plans must screen for behavioral health disorders, so depression and anxiety. And we added that question into the health plan member survey around that time to monitor that progress. We also do ask the plans to report on their screening rates as well. We also, in addition, have a quality alignment measure set around depression screening and follow-up. That's a reporting measure, and so we'll be getting those results in October of this year approximately. And so we'll be able to monitor that over time and be able to compare that with the plans that cover California Department of Healthcare Services and other national plans to see where we rank.
Thank you. I really want to thank you again for the reports and looking at what's prevalent, what diseases are prevalent in our population is very important because you need to identify what's there so we can target it and improve because we want people not to get. It's one thing to provide what they need to cure them, but or we have a disease. But if you can maintain or prevent chronic diseases, that's a beautiful thing. And I thank you for this, and I look forward to the work in 2026 and future reports. So thank you very much. Thank you, President Taylor.
Thank you, Mr. Rubalcava. Dr. Logan, I remembered as Ramon was going through his, and I went back, the PPO basic member population where we're looking at all of this care and catching them, so that they're taking care of themselves. I just wanted, what is a high opportunity member? Is that somebody just because of their illness?
I can weigh in on that. The high opportunity is sort of a defined population or a segment that Included Health are focusing and targeting on to get them engaged and get them into high intensity case management. So if you remember, we had that, I don't remember the number of the slide, but it showed like 6 kind of buckets of population. And those are the ones that are identified through internal referrals or claims data that they received from the TPA or referrals from providers. And those are the ones that they reach out to by telephone to try to get them engaged. So it's anybody with sort of chronic conditions, recent,
Okay.
yeah.
So I think I'm looking at the bucket. I think it's on page 15. 17? Oh, there you go. Recent house. Okay. So I think what I found interesting, because as an HMO patient, this was not on the bingo card for me, was high risk spine. So when I was 39 years old, I blew a disc, and that was not an option, was surgery. So I thought that was very interesting. And then acute care management, was looking at that as well. As I'm not clear on what that means.
Yeah, it's from one of their care and case management programs that just reaches out to people who've been recently hospitalized.
Okay.
Yeah.
And sort of, I think a lot of this has happened for HMOs. I mean, I've had an HMO since my career. I've been in state service for 30 years, and I think just recently I started getting contacted either for myself or my husband after a hospitalization. So it wasn't practice before. So we do appreciate that on the HMO side, but since we're just starting this on the PPO side is what I'm understanding with the Included Health, correct? And we expect that to help the outcomes, generally speaking, for these PPO folks.
Yeah,
Maybe bringing some costs down. I'm so sorry.
Yeah, that is the hope. The HMOs have historically been doing this for longer, and while the PPOs do it, and certainly our prior PPO did some of it, we really wanted to have a greater investment and focus in this type of whole person care care and case management, particularly for these, high-cost members who are particularly vulnerable. And so that is why we engaged Included Health, because of their expertise in really finding these members, engaging these members, and helping them to get the services that they need. But yes, basically, we're trying to mirror what the HMOs have done sort of reflexively for longer in the PPOs.
Okay, excellent. We hope to control some of those costs, I assume, with that.
Yes.
Yeah.
And also, if I could, this goes all the way back to the PPO procurement from last year. One of the things that we highlighted was the fact that that the quality with our HMO associated with our HMO products was just higher. And so what we're trying to do now is replicate the mechanisms that lead to that higher quality in our PPO. That's a lot of what Included brings, and the general approach is now similar. So we're hoping over time to see a narrowing of that differentiation between the two.
That would be excellent for our prices overall. Thank you. Mr. Pacheco?
Yes, thank you. Thank you, Dr. Elders, and thank you, Dr. Logan, for your presentation. I do appreciate this material. I want to go back to what is a population health, and actually on the medical cost of diabetes, and the most expensive drug, which is the GLP-1s. And it appears that it's almost like 65% of the total diabetes spent for the basic, which I would assume it's the 617 million. Is that correct?
That was the total spend for basic and Medicare, both medical and pharmacy. And then on the right side, that 17 to 19%, that's a total of our pharmacy spend for Optum only. So I apologize. Based on the data we had available at the time, you can't do sort of like an apples to apples comparison between the left side and the right side of the slide. But it really just to give you an idea of how much we are spending in this arena.
Which is enormous. And I'm just wondering, I know that about a year and a half ago, we were going to create some sort of framework to address the GLP-1s to help us understand, formulary construction and so forth. And I'm just wondering that that's something that's still in the works.
I think what you're talking about is sort of us getting very structured reporting from our pharmacy partners on what that spend looks like on a routine basis. And we are now getting that. It's still in the sort of early days of that reporting, but we're routinely getting on a quarterly basis what the spend is on the GLP-1s for diabetes and also for obesity, because two of our pharmacy partners do cover it for certain members who are very high risk, who have obesity. And so we get that information on a routine basis from our partners, and also discuss it with them on a routine basis in the context of what else we're doing for these members in terms of lifestyle interventions to help support them while they're on the medications, or even, perhaps starting with the lifestyle interventions to try and prevent the need for the medications. And so we believe that we're making some headway in understanding how the drugs are being used in our membership, to what extent and what the costs are, and what other things we can possibly explore to better support members outside of the medications.
Excellent. And in terms of, so you are actually implementing more of a wellness program at first before trying to go into the GLP-1s.
Well, we are looking at that. Currently, there's so many options, and there's not necessarily a consensus on what the best type of wellness program is, other than lifestyle interventions are necessary to support members on these medications. So we're still trying to explore what would be the best option, I think is the best way to put it.
Yeah, and what's really interesting with this spotlight for diabetes, and maybe it doesn't come through here, but how much the costs for diabetes have shifted over the years. If you were to look at the cost of diabetes even 5-10 years ago, it would be much less on the prevention side and more on the treatment side. Diabetes can cause blindness, leg amputations, heart attacks, very serious and costly impacts of diabetes. And so what we're trying to do with diabetes prevention, wellness programs, GLP-1s, is to shift that from treatment to prevention, so that kind of and with our health program overall is really to have that really heavy focus on prevention.
I actually have noticed that like for instance, dialysis services are not included here. If or it is, it may be it's a smaller percentage. So
Yes.
I feel that's important. Interesting, very interesting. The next question I have is with respect to the included health and the engagement process. I saw some of the statistics which are really interesting from January 1st to April 30th, 2025. And I'm just wondering, I know that when we first began this process with included health, there was some hiccups with respect to, getting people involved. And I'm just wondering if that has resolved. And also, with respect to the services that were received, were there anybody who didn't feel satisfied or weren't very happy with their service? If you can elaborate on that.
I can take the first stab, and then Christina, you can add on. First of all, yes, there were some hiccups in the beginning, without a doubt, as we're all aware. I think that comes with any big transition. And I think that there were individual people who did not feel that their first experience with Included was what they hoped it would be. However, I do think that has improved. A lot of that has been due to Included and CalPERS working together very closely to try and both help Included understand our members better, and Included doing their own work to understand our members better, and to follow up with members who maybe did not have the best first experience. A lot of that, I think, too, had to do with the volume in the beginning, because there were just lots of questions, and there were some people who needed new providers, and that created quite an impact on Included staff, and so they had to work through that. But I would say it absolutely has improved, and again, largely through the hard work of Included staff working with the CalPERS staff. What was the other question? Sorry.
With respect to if there were any, I believe, if there were any filings for grievances or claims of that nature.
There were many grievances, and I think both the Included staff who work on grievances and the CalPERS staff who work on grievances work very hard to address all of those.
Oh, wonderful.
In particular, I know our CalPERS staff was very heavily engaged with the membership and worked very hard to ensure that any issues were resolved. It was really quite impressive, I have to say, that our CalPERS grievance and appeals staff did so well at really trying to support members through the transition.
And I noted in the last presentation on the PBM how we had that training with our grievance and appeals team and the Included Health and Blue Shield grievance and appeals team. And that was in part because of the grievances that came through. And so that was incredibly valuable in allowing Included staff and Blue Shield staff to work side by side with our CalPERS staff to understand where our members were coming from and what their particular concerns were, to address them specifically and individually. So I think it was a big step forward.
And that's excellent. And just on a follow-up with respect to that, since we now have Included Health, do we have a new reporting process where we're reporting these grievances and claims and so forth, or is it similar to what we utilized in the previous systems?
It's essentially the same system, particularly on the CalPERS side, and we feel that system works fairly well. Included, I know that they have sort of increased their staff so that they're better able to address any grievances as soon as they come in. But it is the same type of system, and we do track and monitor those grievances on the CalPERS side, so we're able to sort them in terms of what the grievance issues are and what carriers they come from, so that we can monitor for any trends going up or down or any particular issues that seem to be evolving.
Excellent, and I think that's where I feel we're on a good track then in terms of it. And thank you very much for letting us know about the improvements from the hiccups. So that's good. Thank you, and those are my questions.
Mr. Pacheco, if I could just add one other thing, which is that I think new entities that are new to CalPERS frequently bump up against the same challenge, which is that they don't appreciate the extent to which CalPERS members are just different. Their expectations are higher and they are higher touch. So included almost doubled from the outset the number of folks that were dedicated to serving the CalPERS population, and that number wasn't high enough. And what we learned as we did analysis, Julia's team and including the grievances and appeals folks listened to hundreds and hundreds of calls providing feedback to Included Health. It was the core of that in-person meeting where Included flew their folks from across the country and other places in California, and Shield folks came to CalPERS for a few days, was that you really need dedicated CalPERS folks to be working with CalPERS folks. So because there were higher call volumes than expected early days, the people who had been trained in the fall to be on the phones with CalPERS members were also generalists. So they didn't have the depth of understanding, the extensive training and so forth. And really the key point where we saw the transition was where the surge folks who were being added were no longer necessary because we had trained up all of the people who were going to be dedicated to the CalPERS membership. And as we continue to review calls, we're seeing the benefits of that approach. Ms. Walker asked if there were lessons learned from the PPO transition that we're thinking about on the PBM transition. That is a big lesson there, and we're working with CVS to make sure, as Julia noted, that all of the folks who are going to be serving our members are CalPERS dedicated folks, and that's I think really helpful in smoothing these kinds of transitions.
Thank you, Don. I really appreciate that comment and so forth. And I do appreciate what you said about in terms of bringing these folks together and having almost like a focus group. And I think these are things, in my opinion, I feel these are things that we should, as a board, we should learn. We could learn from, as good case studies on how to even improve the system even better. So yeah, I would maybe something we could think about as an educational item in the following year. Thank you, sir. That's it.
Okay, thank you. Any more questions from the board before I go into public comments?
Yep.
Oh,
Yep.
I'm sorry, Mike. Go ahead.
I think David had.
And
beat me
David,
to it. So, either way.
do Mike first.
Thank you for the report. I know prevention has been mentioned a lot here, and I think, there's no silver bullet. There's genetic history and family history of diseases, and, even if you appear perfectly healthy, you could still have high cholesterol, et cetera. So my question kind of looks at, does the insurance companies have the data, or do we control, review the data to see, is there an ROI on the prevention programs that we have? Because, of course, care and case management is important, but if we can look at our data, maybe through AI, which we're going to talk about later, to really get some more intense interventions early to prevent, further disease progression. Where are we in kind of the data set, and do we, I assume you all review it? Does Included Health also have kind of the lifestyle coaching? I know we all need a little bit of reminders every once in a while to get back on track. So where does that prevention lie?
Yeah, in terms of the data, the folks who have the data is us. We have a really, really strong data warehouse that has claims information, it has cost information, so it's really our source of truth in terms of the health and sickness of our members and where we can intervene. So that's something that we're constantly doing is, you saw Lisa's slides about chronic disease and things like that. That's something that we do all the time in terms of the health of our members and comparing the PPO to the HMO and Medicare and where we can intervene. And we certainly do work with our carriers and go over that data with them really on a quarterly basis to understand where those acts of intervention can be.
Perfect. I know that it seems like whenever you go to a primary care doctor, the time that's allotted keeps shrinking. So, the touch
Certainly
point
does.
there isn't there for the coaching on the primary care level. And so, what other services can we provide? And it looks like we're looking at the data. So, thank you for that.
Yeah. Thank you so much for the reports, the information, and all the work that the team's been doing. As you know, I've particularly been focused on the behavioral health and the integration into these kind of care team models, and I'm really encouraged to see it continues to be more recognized, more attention, more resources, and more focus, both from our end, but also throughout the industry. And I like to think with the American public at large is, I think we're seeing the reduction of stigma, more willingness to reach out for help, and less pushback on the screening questions and stuff. I think people are doing a better job of taking it seriously and not just making sure they don't say yes to anything that's going to, kind of derail them in the process. So, yeah, so very encouraging, very pleased with the focus and the progress. I think included health hopefully will be another big step forward with us. One of the things that I really wanted to kind of know is, are we getting more granular when it comes to, when we talk about access to what level of care? For example, over the last 2 years or so, I've had lots of different primary care physicians assigned to me. A few of them I've never even met, because by the time I finally got an appointment, there had already been turnover and I was dealing with someone new, and didn't really get to know them or see them. But the sophistication of the electronic medical records systems was so good that when I came in, the 3 or 4 people that I had personal contact with, whether it was a medical technician, a vocational nurse, a registered nurse, a nurse practitioner, a physician's assistant, and occasionally a medical doctor, they really did have all the information they needed to deliver what I needed that day. And on the rare occasion, every 6 to 9 months, when I see the endocrinologist, whether it's the first endocrinologist I had 2 years ago or the most recent one that I had, they had everything they needed. And so I'm very impressed with how much that's improved over the years. On the other hand, I hear from a lot of members with behavioral health issues that kind of change and that kind of turnover is really disruptive, because they're practically starting from scratch, despite the little the information in the medical record. When they show up for their 35 or 40 minutes and have to go like from start to finish with a new therapist. And most recently, I talked to a member who is very frustrated because the ability to see the psychiatrist, I mean, routinely people are told your first appointment is going to be in December or January of next year. But meanwhile, you can see, a social worker, or meanwhile, you can see, someone who is, a therapist, but they're not a psychologist, they're not a PhD, they're the level of care. Do we really track what level of care people have access to within the behavioral health realm to be able to get a better picture of how that is evolving over time? So long-winded question, so sorry.
Yeah, I can go ahead and start. So mostly just sort of comments on your comments. I completely agree that the electronic health record has become that thread of continuity for primary care, for virtual care. As an example, Included Health has an Epic capability. So they're able to see, if you see a virtual provider through Included Health, they're able, and your regular provider or network is through Epic, they're able to see your most recent visits and sort of follow along so that you don't have to necessarily, give your whole story over and over again. That can be very frustrating, I know. On the behavioral health side, it's, in general, it's that thread of continuity with the EHR is much less and seems to be lacking just as a matter of course. One of the things I mentioned in my presentation was around Blue Shield and how Blue Shield is now going to be bringing in all of their behavioral health services and carving it back in from Magellan starting in January. And so the hope there is that that continuity that you have on the medical side will now be on the behavioral health side. So we're starting to see those sort of changes that the system recognizes the fact that behavioral health shouldn't be this like wicked stepmother on the other side. It should really be integrated and part of the medical system and medical ecosystem as a whole. And so I think we have a long way to go with that, but there are changes and developments that are happening.
Yeah, appreciate that.
And the other thing that I would add to that is you touched on so many issues that are difficult and problematic in behavioral health care right now, not just access, but also workforce issues. And so, CalPERS continues to work with our partners at Covered California and DHCS and the Office of Healthcare Affordability on those access issues, which seem to disproportionately affect behavioral health. Your example of a psychiatry wait time of 7 to 9 months is not uncommon. Additionally, as to working on a workforce, we're also working on better ways to measure access and talking about different types of measurement, particularly to get at behavioral health and some of those disparities in different levels of access. So the work is ongoing, just obviously no magic bullets yet.
Yeah, well, I certainly really appreciate all that work and just, that it's such a qualitative difference in the types of treatment and therapy plans for where there's that confluence with the behavioral health versus more or less strictly medical kind of plans of treatment that are primarily pharmaceutical based, where it really doesn't matter to have, to build rapport and relationship with specific practitioners versus the behavioral health where just in my experience, the first 3 or 4 visits is just determining whether this is the person for me to be dealing with, let alone making real progress in terms of, trust and everything that needs to be there. So, yeah, very, very different. And I don't envy the challenge you face trying to grapple with those differences in an environment where the almighty dollar really rules a lot of the decision-making on the part of the people that you're negotiating with on our behalf. So thank you.
All right, thank you. Ms. Walker?
This is off topic, so if we're at the end, I can wait until we're at the end if nobody has anything else.
We are at the end. I just have public comment left.
Okay, so just one thing, hopefully one thing. So, I've been reading about our Health and Human Services Secretary and how he's changing the landscape on vaccines and what's approved and what's not. I know you guys are all over that, right? Because this is what you do. But I also know that the ones that are approved by CDC have to be covered by insurance. And so what is a potential impact on us? Because I know we changed some on the COVID boosters, right? On who gets them, who should get them. So does that mean our costs go up, or just what are you seeing, or what do you think you're going to see? And
so just at a very high level, this is a challenge that the state of California is grappling with right now. Since the beginning of public health, we have, since the beginning of the CDC, we've put faith in federal guidelines to make determinations about what vaccines we cover and which ones we don't. And that is, that source of truth is, it has been put in jeopardy, frankly. Julia can add detail to this, but I know the Department of Managed Healthcare right now is grappling with this very question. There have been discussions about whether we need to look to other countries to make those determinations or whether they're a better source. I think they are landing in a pretty good place. Do you want to?
Yeah, so that's definitely been a hot topic among our colleagues at Covered California, the Department of Healthcare Services, Office of Healthcare Affordability, Department of Managed Healthcare. Across the board, the clinical folks have been talking a lot about that, realizing that ACIP, that committee that makes decisions on vaccines, may not be our
Best
source of truth. Moving forward, we're trying to find an alternative. The Department of Public Health is leading that charge and making decisions around what body to really rely on. There's a group in Minnesota that makes those sort of clinical decisions that actually used to inform the work of ACIP that we've been leaning on and talking to in terms of these conversations. We're at an advantage, really, as opposed to our colleagues at Covered California and the Department of Healthcare Services, because a lot of those childhood vaccines with Medi-Cal and Covered California are paid for through the federal government, through the Vaccines for Children program. Our vaccines aren't. And so we have the ability to direct our plans to pay for them at no cost for our members. And if there's that division with the federal government, that's what we intend to do, is to use the power of our state and align across our state. And that's sort of the power of this alignment that we've been doing in general, to be able to have that consensus. So for now, we've been checking the ACIP website. There have been no changes. I know there's a lot of talk about it, but there are no changes. So we anticipate that for the fall vaccines, there will be no changes, that everything will remain covered as is.
Well, thank you.
Yeah,
Because vaccines are expensive.
They are very expensive and getting more expensive. And you probably noticed there's a lot of marketing around vaccines in the past few years. And that's been an increasing proportion of especially our Medicare spend.
They're expensive and they're very cheap because they are efficient
Well-
ways of preventing disease and.
Oh, no, I agree
yeah.
with that.
No,
but
I know
just-
you do. I was just
Yeah, that's a good
felt
point.
compelled to make
Yeah.
the point.
Oh, yeah. Thank you. I
All
knew
right,
you guys
thank
were on
you,
it.
everyone. I am going to move on to our public comment. That's Fred Thangji. May not have said that correctly. From the National Union of Healthcare Workers.
Good morning. Fred Seavey, National Union of Healthcare Workers. I'd like to comment on the behavioral health portion of the presentation. But first, I'd like to express our appreciation for the work of the board, the Pension and Health Benefits Committee, Dr. Logan, Dr. Albers, Christina Almeida, and the other staff on this important behavioral health initiative. Secondly, I'd like to urge you all to continue and to intensify your work on behavioral health. Our union represents about 7,000 behavioral health therapists across California in inpatient but largely outpatient settings. And these include psychologists, licensed clinical social workers, marriage and family therapists, addiction medicine counselors, licensed professional clinical counselors, psychiatric RNs, who treat patients with diagnoses ranging from depression, anxiety, substance use disorders to bipolar disorder, schizophrenia, suicidal ideation.
And they continue to report substantial problems, some of which have been, referenced by board members here today, but problems with ghost networks, with difficulties providing timely and appropriate care to their patients, problems with continuity of care, reimbursement rate problems like the ones that the chair mentioned, and also health plan practices that violate the Mental Health Parity Act. The majority of the therapists in our union work at Kaiser Permanente, where they report the most serious and persistent problems. And as perhaps you're aware, Kaiser right now is under a state-ordered multi-year corrective action plan due to its serious and systemic violations of state mental behavioral health laws. So once again, we think that the work of you collectively is very well placed, very strategic, and can bring about long overdue reform to CalPERS health plans. Thank you.
Thank you for your comments. And one more time, I want to thank the panel, Dr. Logan, everybody, Dr. Elizabeth Albers, for
You need to unlock your iPhone first.
sorry about that, for your great presentation. So, all right, we are gonna take a short break. That would be till 10:55 for 15 minutes. See you back at 10:55. artificial intelligence and the growing role it plays in the health insurance and healthcare delivery. Here to present is Christina Silox, Research Director for Digital Health with the Duke Margolis Institute for Health Policy, along with, and please forgive me if I say this incorrectly, Keisukena, Nakagawa. Okay. I can do the last name. It was the Kasuki part that I was not sure of. Director of Strategic Impact and Growth for the UC San Diego Health Center for Innovation. Thank you both for being here, and begin whenever you want. So thank you.
Good morning, everyone. Can you hear me okay? We're good. Jared Chinneberry, CalPERS team member. So today we're joined by two distinguished guest speakers who will discuss artificial intelligence and the evolving role it plays in health insurance and healthcare delivery. As just mentioned, Dr. Keisuke Nakagawa from UC San Diego Health and Dr. Christina Silcox from the Duke Margolis Institute for Health Policy. Though AI isn't exactly new to healthcare, the pace of innovation in recent years has been remarkable. We're seeing a surge in investment, development, and adoption of AI technologies across a wide range of applications, many of which directly or indirectly impact our members. To put it in perspective, in 2025, the American Medical Association reported that 2 in 3 physicians are now using AI. That's a 78% increase from just 2 years ago. And it's not just physicians. All of CalPERS health insurance carriers and PBMs reported that they have either implemented or are considering implementing AI applications. At CalPERS, we're taking a proactive approach to this growing trend. One of the key priorities is transparency and accountability. And of course, transparency is the foundation of accountability. Before we can hold health plans and providers accountable for how they use AI, we need to understand what they're doing or planning to do with it. Yeah. To that end, in March this year, we compiled an inventory of artificial intelligence solutions that CalPERS health plans are incorporating into their lines of business. The types of AI solutions that they reported span the full gamut, including risk identification, customer support, prior authorization, care connection, and more. And while many of these solutions are still in the development phase, it's clear that health plans are investing significant time and resources in the planning, testing, and piloting these technologies. Improving transparency around AI across the healthcare ecosystem isn't something that CalPERS can or should do alone. As with many of our other initiatives, we aim to align our efforts with other health agencies such as Covered California to create a unified approach to transparency and accountability around how health plans use AI, particularly in decisions that could impact members' access to care. We're also committed to ongoing engagement with health plans, providers, and outside experts like the panelists joining us today. By working together, we can better understand both the opportunities and the challenges that AI presents, and ultimately figure out how to best maximize the benefits of AI while minimizing the potential risks. With that, I'd like to introduce our panelists. Dr. Christina Silcox is the Research Director for Public Health at the Duke Margolis Institute for Health Policy. Her work focuses on designing and implementing policy solutions to advance innovation in health and healthcare and improve regulation, reimbursement, and long-term evaluation of medical products with a focus on digital health and AI. And Dr. Keisuke Nakagawa is the Director of Strategic Impact and Growth at UC San Diego Center for Health Innovation, where he leads new ventures, strategic partnerships, and growth initiatives that accelerate the adoption and scale of innovative health technologies. His work focuses on co-development of novel technologies, validation in clinical settings, and maximizing impact through venture, operations, and policy. We know Dr. Nakagawa best from his previous role at UC Davis Health, where he was a Director of Innovation, spearheading their digital innovation efforts. And real quick, before I turn it over to our panelists, I'd like to thank team member James Arengaren for the extensive work that he put into organizing this session and compiling the AI inventory that I just mentioned. All right, to kick off our discussion, then I'll turn it over to Dr. Nakagawa. What's yours?
Thank you, Jared. And I want to thank the board for this.
Microphone.
Oh, good morning. Thank you very much for the opportunity to present this morning to the board. We're really excited to share some of our experiences on AI at UC San Diego Health. So I don't think we'd all be having this presentation if it wasn't for ChatGPT. So I wanted to open with a quote from Sam Altman. The AI you're using today will be the dumbest AI you'll use in your lifetime. And when we think about AI, especially in the context of healthcare, we're really approaching this as using new technologies, right? Cutting edge technologies that we're implementing into the health system. But when we really flip the lens to the people who are building this technology, they're constantly racing against the speed of innovation. And so I really try to remind myself of this quote pretty regularly, because we don't really know what is going to be happening over the next 3 months, 6 months. And most likely the technology that we're seeing and implementing today is going to be outdated by the time it's next year. So I think we, as a learning health system at UC San Diego, we're always trying to balance this lightning speed of innovation and change, which takes a lot of time. You know, it takes a lot of trust, it takes people and process. And so how do we really close the gap between the speed of technology and the speed of change, and doing that in a very responsible and collaborative way? So why do we need AI in healthcare? The real human limitation is that we can't be at every patient's bedside every second. And we cannot review every chart every instantly. And we cannot intervene on every single patient at the same time. So this is where a lot of AI augments and complements some of the human limitation, is this ability to work with AI so that we can have real-time insights, augmenting clinical decision-making, and really being able to improve patient care at scale. And I think that partnership is really where we see the synergy between the human work and the AI technologies that we're implementing today and considering. So to zoom out a little bit in terms of how we look at the broad classifications of AI technology, I'm going to start with two very macro buckets, right? So there's predictive AI and there's generative AI. So predictive AI, as the term indicates, is typically trained on historical data to predict a certain outcome or a certain event. So it could be predicting the risk of a serious condition like sepsis in the ED in the next 6 hours, or something like the flow or occupancy of the hospital. So what will the bed capacity be in the next week or 2 weeks? So that's like the predictive AI bucket. And then we're seeing a newer kind of type of AI called generative AI, which I think is what brought a lot of this excitement and adoption at the everyday level with generative AI. And that is really applying AI to summarize information, to be able to extract information from text and being able to then adapt it or modify it in a certain way for different consumption. So generative AI is really an opportunity for us to create kind of new content off of the information that we already have in kind of the human collective. And diving a little bit deeper into some of these specific types of AI technologies that we're looking at the health system. So machine learning is much more around the predictive AI. Learning patterns from historical data to make certain predictions like sepsis or occupancy rates of the beds. Natural language processing gets to be a lot more around interpreting human language. So then now we're, if you think about a physician or a clinician charting at the bedside, right, we're often writing it in paragraphs. So natural language processing allows us to take that more unstructured text and extract it into a more structured data set for other analyses or other predictions that we can make. Now we shift to computer vision, and that's where you start thinking about x-rays, CT scans, pathology slides. This allows us to kind of almost operate on the pixel level instead of on the word level. And it also allows us, as an example, detect like a lung nodule on a CT scan that's suspicious for cancer that we want to follow up on. And then the large language models is really a subset of natural language processing, and it's able to just absorb a massive corpora of text, right? And being able to then take that information, process it, and then summarize it, or even pre-draft messages that a clinician might be drafting to a patient. That's a large language model. And the next frontier that we're really exploring is bringing all these different AI technologies together into multimodal. So I had a professor explain to me, what if we could just, the number one on a that's handwritten is no different than the actual one in a database. So now images, video, text are all unified into a more cohesive kind of underlying understanding. And that's really multimodal, and we see a lot of opportunity to then bring in EMR data, maybe a camera in the OR, and all these other aspects like X-ray CTs all together into a unified kind of language or understanding. How do we actually then implement these technologies? I want to briefly touch on some of the governance that we've put in at UC San Diego Health and across the University of California. At a high level, we look at it as could we and should we? So could we really touches on, can we actually do this? And that comes from a technical standpoint, regulatory and policies. Could we actually, are we allowed to do this, right? And then do we have the budget and the infrastructure to actually implement? But that's not really the full story, right? Just because we could do it doesn't mean that we should always do it. And so the should we really touches on the ethics of the use case that we're considering, and making sure that we as a health system have the sufficient safeguards to actually be able to responsibly implement a project. And so the could we, should we model really helps us to look at this from a multifaceted level. And in terms of a governance structure, we have this Health AI Committee that's spearheaded by our Chief Health AI Officer, Karandeep Singh. And he works very closely with many different experts from the health system, from legal, compliance, risk, cybersecurity, as well as operational and business leaders to really work together to make the right decisions around what projects are ready for implementation at our health system and at scale. So I want to really kind of touch on some of the unit economics of AI, because this is really what's driving a lot of our adoption and strategy. So this is a framework that I've adapted from Professor Agarwal at the University of Toronto Business School. So on the x-axis on the bottom, you see the quality of AI prediction. So as you get more toward the right of the graph, the quality of AI predictions is increasing. So as the quality of AI predictions increase, the substitutes of those actually decrease in relative value. And so, for example, human predictions actually decreases in relative value as the quality of AI predictions increase. But that's not all of it. So what does actually increase in value is the substitutes. So a really important substitute as the quality of AI predictions increases is the value of data. As you get more and more accurate in those AI predictions with the algorithm, you need better and better data to achieve higher and higher levels of accuracy. So the relative value of data as a substitute, actually as a complement, increases in value. Another thing that increases in value is human judgment. So as we're making better and better predictions, we want to make better and better decisions off of those predictions. And then finally, the action. Even if we're making good decisions, we need people to actually turn it into concrete actions and outcomes. And so how does this apply on the medical context? So human predictions in the context of medicine, healthcare is diagnosis, right? Medical data is medical data. And then human judgment is actually the management. There's a lot of different clinical guidelines, and there's many different ways that we could implement those guidelines based on the patient. And then ultimately with the action, there's the treatment and the counseling of that patient to really drive the actual outcome, from those engagements, those interactions. So when we really think about it, the human touch actually becomes more valuable as AI gets better and better. And that's really what makes me very optimistic about these technologies, is that what we're seeing is the human element of clinical care, of patient care, is becoming more and more important as a part of the larger formula.
Can I interrupt you and ask a question?
Sure.
On that graph. So, and I watched it change to what's in our slide deck, but the human prediction where you say is diagnosis, it's going down. So you're saying that diagnoses ability is going down with more AI, or?
This is the relative value. So if there's human predictions and AI predictions, if one is getting better and better, the need for the alternate, the substitute, is decreasing in relative value.
And that's the red line.
Yeah, and that's the diagnosis.
So how are you defining then that the human touch actually matters then? Because I'm having a problem with that. Because it sounds to me like you're disregarding doctors' diagnoses because it's not AI.
Well, I think I'm going to actually touch on some of the future vision of how this plays out in the final slides. But to answer your question, as something is augmenting our capability to predict certain outcomes or certain diagnoses, that's not really going to necessarily translate to better patient outcomes or better patient behaviors. And that's where the human touch really comes in, right? Is we may be able to know that this patient is at a higher likelihood of having cancer, like lung cancer, right? But now it's the human touch that's going to drive whether they stop smoking, right? Or whether they have better behaviors. And that's where I'm kind of indicating on the treatment and the counseling.
Okay.
Doctors really play a very important role, or clinicians play a very important role in that relationship with the patient. And I think that's becomes an extremely important and more increasingly valuable component of the patient care as we work closely with AI moving forward.
I get you. All right. Thank you.
So when we think about how we apply some of these AI projects, at UC San Diego Health, we've implemented a number of principles around making sure that we're much more human-centered with how we look at these technologies. Transparency is a really important element of in understanding how we implement AI. And so we've actually published this on our website. And so how do we actually put these in action as principles? So one example is drafting replies to patients. So when we actually have, patients are constantly messaging their clinicians. And so there's an increasing inbox of messages that you have to reply to. And so now what we've done is actually create a tool where the physician could choose whether they want to start with a draft or actually start from scratch. And so the status quo is starting from scratch. But what these large language models and these AI technologies can do is it can look into the medical records to then tee up an initial draft that then the clinician can actually revise. And so this is what the actual output looks like that was sent to the patient, right? And there's a few things I want to point out here. First is that last line where it's indicating to the patient, the recipient, that this was auto-generated by an AI and then it was edited by your physician, right? So I think that transparency is very important in building the relationship and the trust, with the patient. It also supports the autonomy, the independence of the physician to choose whether they want to use the AI tool or they write it from scratch. So there's a number of principles. I just want to give an example of how we apply some of these high-level principles in action for different projects. And I think this is a really great example of us practicing these principles. But AI is always good at throwing us curveballs. So it's so important that as an organization, we're constantly studying and generating evidence around what's working, what's not working, and doing it in a very rigorous way. So UC San Diego Health was the first to do a randomized trial of this technology, and we just published this in Journal of American Medical Association, JAMA. And the surprise was that implementing these technologies, it actually didn't save time for the clinician. It actually increased the time it took for them to read it because it was getting auto-generated. And it also increased the length of the reply. So a lot of the assumptions that we had in terms of efficiency were not necessarily the case, at least in the early stages of this implementation. But it's not all about just pure efficiency, right? What we found, though, was that there was a lot more compassion and empathy consistently in these messages. Because there was empathy built into the tone of the pre-drafted message. And if you think about a very busy clinician who has hundreds of messages that they have to respond to, they often don't have necessarily the time to put in that empathetic tone, even if they would want to. And so this is I think, a great example of empathy at scale, right? Where we're able to augment and support the clinician to be able to draft these responses in a way that they would have done if they had a lot of time at their hands, but do it very efficiently. So I want to come back to, Sam Altman's quote. We're still really at the first generation of a lot of these AI technologies. And so as a learning health system, it's so important that we're constantly evaluating and studying how these technologies perform, what kind of outcomes they're driving, and how do we actually work together in a very nimble way to constantly improve and evaluate the real-time usage of these technologies. And so we're putting a lot of investment in that space as well. And as a quick vision for the future, this is another paper that was recently published in PNAS, the National Academy of Sciences journal, where they found that hybrid clinician AI teams deployed to solve very complex medical cases were actually a lot more accurate than AI only or human only in solving those medical cases. So I think the real vision for the future is a much more collaborative relationship between the physician, the clinicians, and the AI, so that they can actually work together to improve patient outcomes for everyone and at scale. So through this collaborative approach, we really see that with strong governance, a thoughtful implementation, and intentional design, we can achieve a lot better outcomes in partnership with technology. So thank you very much for the time to share our experience.
All right, and then I'm going to be talking about balancing innovation and risks in the use of AI by health insurers. And I want to start by just talking a little bit about how health plans are using AI today. And they're using it in a variety of ways. The first one I'm talking about is just your normal business uses, the same way that a lot of y'all might be using AI. So IT has jumped on the use of AI for their work. Employees are using AI to help with summarizing meetings, to drafting internal communications, all of those types of topics. But we also see it in member services. And some of those examples are, for example, when you call on the phone and ask a question, the agent who's helping you can use natural language processing and other types of generative AI tools to be able to pull up the relevant information faster, and so that they can answer your question faster. We also think about websites, being able to have more enhanced searches, being able to pull more useful information. And so what's the benefit of that? Well, the benefit is it's increased efficiencies for the health plans themselves, which of course could potentially lead to lower costs and lower premiums. But for the patients, it also could mean that they're getting that information faster, which of course is, we think we'd all like to spend less time on the phone with our health plans. We also see it being used in actuarial modeling. So that involves things like projecting future claim costs and testing out plan designs and seeing how they might work. And so what's the benefit there? One is that premiums could stabilize more. They get better at predicting what the costs are going to be, and so premiums can stabilize. There's less fluctuation year to year. And then you can also think about, with better modeling, you can think, are there ways of having more flexible plan designs? Can we try new things now that we can understand what the results might be? So I think that there's some space there that could be really interesting. We also see it in fraud detection, both real-time anomaly detection, which allows anomalies to be picked out before the payment's actually sent, which makes it much easier than trying to claw the payment back, but also allows pattern detection to flag for unusual coding or abrupt changes, and again, be able to open up investigations into that. We see CMS has actually been talking about this quite a bit lately. And what's the benefit there? Well, again, reduce fraud, reduce costs, reduce premiums. But not only that, you also discourage fraud because it's more likely to be caught, which means that, and some fraud involves unnecessary care, which means that your beneficiaries wouldn't necessarily have that unnecessary care given to them. But more clinical uses. Let's start with population health. And we heard a little bit about how that might be used in the health system. And health plans use it sometimes in similar ways to do risk stratification, to understand who might be more likely to be coming to the ER in the next month, who might be more likely to be readmitted. And then also to target preventative health resources, sometimes from those risk predictions. Is someone more likely to fall? Can we send them some help to prevent those falls? Is someone likely to be having problems managing their diabetes? Can we give them some more supportive services to help them better manage their diabetes? And then also, some of those preventative services might be social needs. So trying to analyze who could potentially benefit from food assistance, who could potentially benefit from transportation assistance. And again, trying to make sure that people are getting that preventative care that prevents those costlier, more involved care and treatments required later on. And then we also have claims processing, which I think is where a lot of people have the most concerns. And I'm going to talk about the benefits first, and then we'll talk a little bit about some of the concerns that people have. The first, and some of it is that it might be doing less than you think. So, we talk about automated claims processing. It may just be pulling unstructured data into structured data so that it's easier for a processor to look at. But we might also be using it to make decisions. And there's a variety of ways you can use it to make decisions. One is you can make suggestions that the processor then looks and the human decides. The other is that it might automate the approvals, but still have a human looking at the denials. Or, and we don't see this so much yet, but the full process could also be automated. So what's the benefit there? There's a huge benefit in having your claims processed faster, having your prior authorizations claimed faster, having your doctor be able to see your whether something's going to be authorized or not in real time while they're talking to you, so they don't spend time talking to you about treatment that you're ultimately not going to get. Being able to understand what your costs are going to be because your claims have processed faster, so you can understand where your costs are coming faster. So there's a lot of benefit there, but we're worried about this top bullet, which is accuracy. So I'm going to talk first about some of the usual suspects when we talk about AI risks. And the big one, and we see it in these headlines, about using faulty AI to deny claims incorrectly. So the problem there is accuracy. If we were sure that the automation was giving the correct answer, I think that we would agree that faster is better. But we don't have that faith. And why don't we have that faith? It's because there's very little transparency and regulation in this space. So we don't know what tools are being used. We don't know how they're being built or tested. We don't know how they're being tested on subpopulations. So is this tool going to work for me? Is it generalizable to me? And then we're not sure how it's being monitored. So even if it's started out working, is it continuing to work over time? Which again is something that we know that AI can have challenges with. For generative AI specifically, we also are concerned about hallucinations. So is it just making something up versus doing what you think it's doing, which is pulling information out? And then the final problem the final risk that we have with AI is that oftentimes there's no explanation of output. And so why is it making the prediction it's making? And that can, again, be really important when we're thinking about something like a denial. Why was it denied? How do I appeal it? And with no explanation, that can be challenging, clearly. We also have other risks that we should be looking about. One of which is liability accountability. So who is responsible when AI makes a mistake? And I have a headline here about an airline, a Canadian airline, who had a chatbot, a generative AI chatbot on their website, where a passenger asked it a question about bereavement fares. What's the process for doing a bereavement fare? And the chatbot gave completely wrong information. And then the Canadian airline tried to say, well, sorry about that, that's not our responsibility. And it went to court, and the court said, no, you have this chatbot on your website. You have to do what if it said that you were going to do this, then you have to allow that to happen. And so in America, in the US, that's less clear where the liability and accountability is. so I think there's a lot of open questions about that, and some of that can be taken, can be done in kind of contractual ways, but it's not really been litigated or legislatively determined. We also can worry about many of the things that I said, right? Was I'm saying, okay, well, it's going to get faster. There's going to be more efficiencies that can lower costs, and particularly in claims processing, right? That's one way you could do it. But you could also, in a space where doing prior authorizations takes less effort because it's automated, you could just decide that you're going to do it faster, and that's going to be efficient, or you could say, oh, with the same number of people, I can actually require more prior authorizations. I can require prior authorizations on more things. And so I think that, that potentially is a risk that we should be looking at. And we also see that, and this is the second headline I have around the battle of the bots. So what we're seeing right now with generative AI is that both providers are using AI to write the initial requests, authorization requests. Insurers are using AI to read that authorization request, and sending a response. Now there's AI being built to help with doing appeals. And not only is this the dumbest use of AI, what we're doing is we're completely eliminating the benefit, which is the idea of having increasing efficiencies. And so I think we really want to keep an eye on what's happening in kind of the counterfactual space. But, and this is really important, which is why I have it in a box, I also worry that we're going to be too cautious, and then we're not going to be able to realize the full potential of AI to really improve patient outcomes, patient experiences, and lower costs. So there's also a downside on the other side. So what can we do? Well, the first thing, as we heard about, is putting in high quality governance, and that can be done at health systems. That can also be done at health plans. And you could ideally be transparent about what kind of, how you're doing governance at your health plan. How are you thinking about risk assessment? How are you thinking about testing? How are you thinking about monitoring? There can be based both the governance and some of the development rules and things like that could be based on consensus standards. There could be independent testing of some of these algorithms. We could have disclosure and transparency. And what I mean by that is disclosure, meaning what AI are you using and what is it doing? And transparency, more of that, how did you test it? How was it built? Some of that information. You could also require explainability for certain uses. If you need to be able to appeal a claim, you need to have a reason why that claim was denied. You can also require human in the loop for certain uses. And so there are risk mitigations like that that can be done to make AI safer and more trustworthy. What's the challenge? AI is a really fast-moving space. And so we don't necessarily have consensus standards. We do have emerging best practices, but we don't have consensus standards. I talked about independent testing, but there's not really formal third-party evaluators that are kind of that are available right now. Testing results, like I said, are not always reliable over time due to performance drift. So you may know how it worked when it was first implemented, but do you know how it's working a year later? And we're still learning about AI, especially about generative AI. And so we don't really know what all the risks are yet. And we're still learning how humans interact with AI, particularly over time. And so it's very hard to sometimes predict some of the risks that you might be, even though you have a human in the loop, are they going to move into automation bias where they start trusting the AI more than they should? And so how does that change your risk profile? You have a human in the loop as a risk mitigation technique, but it actually is becoming less effective over time. And then I want to turn a little bit back to kind of the intersection of health plans and health insurance, health providers here, which is really thinking about how do we pay for some of this AI, particularly the clinical AI. And so that involves two things, right? That's payment for the AI tools themselves. And there's some coding and coverage for AI-enabled clinical tools, mostly just FDA-authorized medical devices. There's indirect provider benefit, so it's not paid for directly, but there's increased provider efficiency so they can do more procedures, or there's decreased cost within value-based care, and so the upside risk comes into play. And so there's some payment for AI tools, again, still kind of working this out in a lot of cases. But there's also payment for the AI-enabled diagnosis and treatment recommendations that you were talking about. If those don't comply with standard of care, then will they be paid for? And again, this is very much an open question, and something where I think when health plans and health providers work together to be able to understand how well that AI works, be able to trust that AI, that may be a way of both allowing payment for what we think will actually be the best possible treatment, and also maybe removing some of that generative AI bot war that I talked about. Quickly going over the policy landscape. In the federal space right now, the administration has a real focus on innovation and encouraging AI integration into agency work. So a lot of interest in moving AI into agencies. There are existing regulations around clinical tools and AI tools. The overall, any covered entity is prohibited from using tools that have biased performance or cause biased outcomes. Some of these tools, not all of them, not necessarily even the majority of them, require pre-market FDA review. Some tools, again, require transparency. This is a very limited set of tools integrated into EHRs, but what that has given us, and this is a rule called HT1, is a set of questions that the Office of the National Coordinator said, these are a good set of things to ask if you want to understand about AI, an AI tool. And so that can potentially be used as a building block when you're thinking about transparency. And Medicare Advantage claim tools must comply with all applicable CMS coverage rules around explainability and human in the loop. There was a proposed pause on state and local laws on AI in the reconciliation bill that ended up being taken out right before. We may see that come back up again. And then in California, there is a medical necessity determination. There's a law around medical necessity determinations having to be, again, ultimately made by a licensed human, a human in the loop, although, again, AI can be assistive in that. So when we're thinking about policies, what are some of the challenges? One is defining AI. AI is the loosey-goosey word. And you want to make sure that you are saying, I want to do it for these set of tools. I don't want to accidentally expand that scope and have it be on a bunch of tools I'm actually less interested in. AI is evolving significantly faster than typical policymaking. So that is also a challenge. But requirements on disclosure, transparency, governance, risk mitigation plans, I think these are all really helpful. More specific policies can be asked for when you have kind of more specific use cases. And one of the things I think is going to be really critical for policymakers is really thinking about how to assign accountability to the stakeholder that can most affect that particular issue. And that can also be a little bit of a challenge because of differing authorities. So happy to take any questions, and thank you very much for inviting me.
Of course I have questions. Going back to Dr. Nakagawa, the chart with the humans become more valuable as AI gets better, and the talk of the human judgment. Building AI is built by humans, and we all know that humans have a bit of bias. Whether we try to remove it from ourselves or not, there's always still a bit of bias that lingers on. And knowing that those individuals are building AI has a bit of bias based on those algorithms built by those builders. Do you see that, going back to the comment of sort of having a stupid AI right now, do you see that bias slanting some of that judgment, or do you see somewhere down the road that AI would be able to sort of rewrite if it finds a bias of that sort?
Yeah, that's a great question. Yeah, that's a great question. Well, we're very closely monitoring bias in all of our algorithms that we're deploying at the health system. A lot of the source of the bias is in the data. And the bias in the data is often because it's not always the most representative of the patient population or the people that that algorithm is designed for, right? So I think when you ask about, what is the approach on bias, I think that we definitely need a workforce that is constantly monitoring and kind of overlaying the human judgment around whether a certain decision, right, a judgment is biased or not. I think humans are going to have to play a very important role in making sure that that's evaluated. I also think that AI can serve as a almost objective sounding board as well, right? And so what we need to do is work together to make sure that the technologies are designed and implemented for different types of functions. If there's one that's supposed to serve as more of a sounding board to kind of counter or test some of our fundamental assumptions that might be biased, we can train an algorithm to serve in that type of capacity, right? There's also algorithms where we're just trying to predict the best outcomes along with the humans as a human in the loop model, where we need to look at bias in a very different lens from there. So I do think there's many different approaches to how we can identify and mitigate bias depending on the use case.
And then just in general, between the two of you, when it comes to regulation, obviously we're seeing who can regulate or who should be regulating, right? But do you see more companies putting their own regulations on the use of AI, and or is it still needed at the state?
Do you mean companies having governance around the use of AI tools they're purchasing, or AI? Or
Well,
companies
I
having
think I'm
use
coming
of
from the
AI
approach
themselves?
that you hope that a company does the right thing, right? And uses AI to a model of which it holds true to their board policies or their company business model, right?
Yeah. I think that there's increasing use of governance in basically every company. So we're seeing it, I think health systems in the last couple of years have really ramped up AI governance. I get calls from all types of different types of stakeholders within the healthcare ecosystem asking about how they should be thinking about governance. So I think that this is a space that I think people realize they need to have a handle on. And are very concerned about making sure that they understand what's happening and that they have sort of a level set of quality around the use of these tools.
Yeah, I would agree. And it really is a shared responsibility. As a health system, as you can see, we're constantly improving the governance internally. And if there are regulations that we need to map to at the state or federal level, then we will also apply that. We also work very closely with our industry partners, the vendors, to make sure that what they're doing for governance for their products at the company level aligns with the governance and the principles that we published. So I think there's a lot that we need to do to coordinate, and ultimately, it's a shared responsibility, and everyone needs to work together.
Thank you. So my questions.
Mr. Pacheco?
Thank you. First of all, thank you very much for your presentation. I found it very illuminating and so forth. My question is for Dr. Silcox. With respect to what else should we be watching with respect to the liability and accountability? And I find that very interesting of who should be responsible when AI makes mistakes, and where do we land on that right now? I mean, and also in terms of how do we formulate policies to address that as well? If you can elaborate on that.
So it's difficult. When we think about medical devices, then there's some framework there that very high-risk medical devices, because they go through pre-market approval, the companies that make those devices are given some shield for liability. But devices that are more medium risk, that go through a different type of pathway around clearance, those do not have that protection of liability. And then, of course, like I said, there's many, many tools being used that are not medical, they don't meet the definition of a medical device, so they don't go through FDA. And where liability lies there, again, is open to question because it hasn't been litigated. But most companies try to structure contracts and disclaimers in a way that would reduce their liability. And so we saw that, for example, the first generative AI device got a CE mark, so it got approved for use in Europe. It is a physician-facing tool that's going to give them advice. There's a disclaimer on that tool that says that that company makes no guarantee towards the accuracy of that information. And so again, especially one of those risk mitigations that we talk about is putting a human in the loop.
Right.
And that often does shift the liability to the human and the company around that human who's making that decision.
I think that's a really good example with respect to medical devices where you have a the pre-marketing FDA approval process. It appears that we don't have that for the ChatGPTs. I mean, people are just creating them out of the box without that sort of oversight.
Absolutely. But I will say companies can take on liability. And we have seen examples of a clinical tool, at least one example of a clinical tool that was fully automated. There was no human in the loop. And so that company voluntarily took on the liability for the use of that tool. So we can see that as well. My guess is that they'll end up being kind of distributed liability. And it will be, again, kind of when you think about who can have the most influence on that, where the problem happened.
And then the next question is with respect to governance. It appears that it's still an evolving set of tools. Where do you see us going in terms of having structural, high-quality governance to assess AI risks, the liability, and other variables? Either of you can chime in on this.
As you mentioned, I think we're still in the first inning of AI, and it's extremely important that we approach this iteratively and in a multidisciplinary way. So if we look at our health system, we do have a pretty comprehensive set of expertise, in terms of understanding if there's a major evolution in the AI technologies, how do we then adjust the governance to meet that? But I also think because a lot of these technologies are being built by, industry, we need to work very closely with them to understand what's the current state and also what's coming around the corner. So being able to have that line of sight also allows us to be as proactive as possible in our design of the internal governance. So I think there's a lot that we will need to see as a lot of these technologies evolve.
And I agree with all of that. The only thing I would add is that I think we are seeing that. With AI, I think a lot of people kind of came together and said, this is tricky, and some of our normal ways of doing things don't really work. And so it really has, from a policy standpoint, it's actually been a very interesting experience of all hands on deck, really trying to collaboratively work out how to use these tools in a way that allows us to fulfill their potential, but also make sure that we're using them responsibly.
And the last question I have is with respect to the final, on when you mentioned the policy landscape with respect to California, medically necessary determinants must be ultimately made by a licensed human, having human in the loop. Do you see additional, laws and so forth evolving around this, especially with the proposed pause in the state and local laws on AI?
Yeah. So, like I said, the pause itself actually was taken out of the bill, so
Right.
that's not that did not stay in the bill when it was passed. But yes, we are seeing an enormous amount of activity at the state level around AI regulation, both health specific, both insurance specific, and also more general in ways that would have implications for AI, which is, to be honest, one of the reasons why that this pause was proposed, which is that 50 different, very different state regulations is very difficult for both developers, but also health systems that might span health lines to be able to make sure that they're complying with all these different regulations, some of which may be somewhat contradictory to each other.
Right.
So, the one thing I might suggest is I think the more the states work together, and again, kind of that all hands on deck type idea to make sure that their laws are more complementary, I think that will potentially be a little bit of a fail-safe against some of the preemption talk that we hear.
Very good then. Well, thank you so much for your comments. I appreciate it very much. Have a good day.
Thank you. Mr. Rubalcava?
Thank you, Madam President. Very interesting presentation. Dr. Nakanawa, I thought it was very intriguing, your statement that on the using AI for messages to the patient, that the experience has been that there's more compassion and empathy in these AI-generated messages. Why is that? And I think, you always have the stereotype of, well, I don't know if it's stereotype, but that not every doctor has the best patient manners, bedside manners. So this is something, I guess it's an improvement. But what causes that there would be improvement in the messaging? How does that happen?
Sure. Well, I think every clinician really wants to have a very empathetic relationship and communication with their patients. I mean, we're trained from day one, in medical school, even applying into medical school, nursing school, all the health professions, we are trained to have that empathy, and throughout the curriculum, it's reinforced. I think in the reality of the practice, I think that the difference is we're sometimes so strapped for time that we don't have the 30 minutes or an hour to really think through what is an empathetic message to our patients, right? I do think almost most physicians, if not all, and clinicians have that empathy that they want to transfer and translate to the patient. What AI allows you to do is do it more efficiently and at scale. And that's why I think that human in the loop concept is so important, is because we also have very different ways that we communicate with patients, or what empathy means to me as a clinician versus another clinician. And so by being able to review it before it actually gets sent to the patient, it also allows each clinician to ensure that the flavor of empathy that they would want to convey is represented in that message. And so again, that efficiency allows for the scalability of that communication, and almost unlocks the time pressures that we currently face in the practice.
Thank you. Yes. Looking forward to more development there. Dr. Silicox, I thought it was very interesting on the AA risk. You have the article from United Healthcare about how they're denying, they're using AI to deny claims. So it brings out the whole thing about the profit incentive that you always read about in insurance companies. And another example, United Healthcare, that made the press is where they use an algorithm or AI to upcode to increase acuity or the disease prevalence to get higher reimbursements. So I think it points out to the question of governance and policies. So I guess on the federal level, you said they want to sort of stop that at the state level. But here in California, is there anything other than lawsuits? Is there anything on the books or coming forward that would sort of govern or try to dampen that profit motive or unethical use of AI to drive profits and very, because that one doesn't create bad outcomes for the patient. One look at it that way, but it does
Potentially
increase
cost
premiums
patients
and
more
everything
money.
else.
But yeah, no, I mean, I think that, I think that this is where some of the fraud detection tools come in.
Fraud
And so
protection.
this is an example of the battle of the bots that maybe is a little bit less dumb. So I think that we are going to see AI tools being used by health plans to try and detect some of those, some of those upcoding challenges. But also, again, I think transparency around how did you test this? What were the results? I think is incredibly important. And so when we think about the denials, right? A lot of the newspaper stories kind of focused on the quickness of the denials. They denied 1,000 claims in a minute. Well, if those 1,000 claims are going to be denied anyway, isn't it better it happened in a minute than it happened in 2 weeks? And so the question again is, were those requests going to be denied? And that's the part that I think that there's lack of trust with. And I think more disclosure, more transparency could really help with that.
Thank you. That's very good. Thank you. Thank you, Madam President.
Sure. Any more comments from the board? Okay, so I have two public commenters. I have Luana Conley, I'm sorry, if you would come up to the microphone. And then Keith Umamoto when she's done.
No. You can do a handheld.
Do you want it up there or do you want to handhold it? Oh, there you go.
I'm not good with technology. Speaking of technology, where's my flying car? Faster, accurate, personalized, cutting edge, lightning speed. I think we might want to tamper that back a little bit, you know, that kind of hyperbole about AI. If you ask any health worker or most of your friends that have had experience with the medical profession lately, it doesn't seem like they're very happy with having to use all this technology and spend more time sitting there typing onto their computers than they are have available time to talk to the patient themselves. Most doctors I know and nurses and other technicians are all pretty unhappy. There may be some backdoor administrative benefits, I don't know, but it's interesting to see all the listed benefits, and then it has the potential to negatively impact. And then there's a actual one data point on some real life negative impacts, which, you know, they're legion. They're all over. You can find all kinds of negative impacts from AI and healthcare. I've resisted, as a matter of principle, all the apps that I'm asked to sign up for at my doctor's office after looking at who owns them, and I'm reading their privacy statement, which excludes any kind of liability, like we were talking about before. They have no liability for whatever might happen in the future, or changing their policy, or if everything goes out the window. They don't even claim to keep any kind of privacy. So they're selling data, and I don't really like that. Having my data about all of my intimate health details floating around on dozens and dozens of different apps, when everything under Obama's era, I remember, was supposed to be coalesced into one thing that could be accessed only, very deliberately by your own personal interaction with your personal healthcare person. So I don't want to be a data point for sale. LLM regurgitates existing language and spits out predictable what it predicts would be the next thing, depending on prompts. So it can tell you that every human should eat a rock every day for good health, which has happened. I mean, you're all familiar with the ridiculous hallucinations. So that's where we're at right now. But basically, we are not pixels. We're not, many of us are unpredictable. And we're not just a collection of parts. We really need consistency in care, hands-on, and trust, a trusting relationship to be healed. We're not a chatbot. So, and finally, I just wanted to reference something I heard earlier that pertains to this, is that
You got 14 seconds,
okay,
then.
the government as a source of truth, as the source of truth, and that's if it's a government that you like, and if it's not a government that you like, maybe it will be next, a few years from now, or maybe not. You can rely on some anonymous agency in Minnesota that might be your source of the truth. I suggest we all start questioning authority and reading some books and reading some essays and reading some
All right,
real
thank you.
independent authorities.
Thank you very
to make up
much.
your own mind. Thank you.
Mr. Umamoto?
Keith Umamoto with California State Retirees. Thank you so much, and great presentations and great questions by the board. So I don't take too much of my 3 minutes. I'll try to get into it. Anyway, first and foremost, there's the provider side and the consumer side or the patient side. And we touched on it a little bit during this discussion and Q&A. But on the provider side, the big question is the misinformation that can be incorporated in the AI. And the other is what platforms. My daughter was part of a research study example on the accuracy and completeness of BARD and GBT4 responses to some type of skull-based surgery. So
Yeah.
we have to be real cognizant that the market out there is going to be multiple AI type platforms that are going to be used. Second, on the provider side or the patient side, I wish we could get more into the discussion. We don't have it, but maybe at a point in time, the board will do this because a robot or this AI platform isn't going to do what the doctor said in terms of the human element on how the patient complies with any protocol. And so that we don't get carried away that AI and automation drives us in terms of how the patient care is. Because as we all know, patients don't always go see their doctor or don't follow their doctor's prescription, but the good doctors and the good team of practitioners have that way to make sure that they follow the protocols, including preventive protocols. Preventive protocols on your exercise, and as probably a lot of us say, oh, I should have done this, I should have eaten that. Well, it takes a human partner to a great extent to make sure that those kind of elements happen in regards to all of our healthcare. So those are a couple things I just want to say. This is a great presentation, and for all the union people out there, they understand even more so what I'm saying in terms of how we cannot have technology overrun the human element and the staff elements of every way of life that we're talking about, even with state employees. Oh, we're going to eliminate so many state employees because we got AI platforms out there. So anyway, thank you so much. Have a great lunch.
Thanks, Keith. All right, everybody. Thank you very much for your presentations. It was eye-opening. Lots of, it sounds like we have long ways to go with a lot more information to garner before this is really effective, but really enjoyed the presentation. Right now we are breaking for lunch. Again, thank you folks for your presentation. I want to thank Christina and Keisuke and Jared, so thank you very much. Do we have time for a whole hour?
Yeah.
Oh, we do. We have time for a whole hour. So we will be back at 1:05. That is our scheduled break time. And we hope everybody enjoys lunch. Thank you. welcome back, everyone. I hope everybody had a good lunch. We're going to get the afternoon started with a discussion on the 2022 to 27 CalPERS strategic plan and key priorities on the horizon for the final fiscal year in the plan. We're joined by several CalPERS leaders. Here to moderate, wow, it is lunchtime, is Sabrina Hutchins, Chief of the Strategy Projects and Data Analytics Division. So I'm going to throw it over to you, Ms. Hutchins. Thanks.
All right, very good. Good afternoon, everybody. Sabrina Hutchins, Chief of our Strategy Projects and Data Analytics Division. I'm happy to be here today to facilitate our session focused on our CalPERS enterprise strategy. And our presentation today is going to be conducted in collaboration with many of our executive team members. As summarized here in the agenda, I'll first be kicking us off with some background information about our strategic framework and reporting system, and then I'll hand it off to our executive team, who's going to focus in on each one of our individual strategic goals, talk a little bit about their top priorities as it relates to the progress we've made related to each one of our goals, and then what is on the horizon for this fiscal year. And then it will come back to me for an update around our planning process related to the development of our next CalPERS strategic plan. So in planning for this session, we did keep in mind your overall 3-day agenda. You've had a full day yesterday in the investment arena. This morning we focused in the health area. And then tomorrow you have a full session around our stakeholder perception survey results. So those are 3 major components of our plan. But again, we want to look at this through the enterprise view. So we hope this session is a complement to those other discussions. And then also give us the opportunity to focus on our 2 additional goals around organizational excellence, which looks at us internally as an organization, as well as our very important member experience goal. As part of your material, you do have the 2025 through 2026 business plan. This is a summary of each one of our initiatives that the organization will take on this year. We don't plan to review each of these initiatives in detail. However, we do welcome any questions or feedback. And then speaking of questions, we would like to hold those till the end of our session to just make sure we give each one of our presenters time to get through their individual segments of the presentation. But of course, if you have any burning questions, feel free to jump in. So with that, I always like to start with our foundation as a reminder and reinforcement of why we are here, and that all of the components that we're going to be discussing today are in alignment with our purpose, who we are, and what we want to achieve. As a team, we're inspired by our vision and our mission to serve those who serve California by delivering retirement and healthcare benefits to our members and their beneficiaries. And in our day-to-day work, we are guided by our core values. CalPERS sponsors a comprehensive strategic planning framework, and this visual highlights each layer within that framework. As I mentioned, our vision and mission provides insight to our aspiration and clearly states our purpose for existence. Our strategic goals communicate what we want to accomplish over the long term, and our objectives clarify how we are going to achieve our stated goals. And our measures, of course, provide those meaningful progress indicators. These top 3 layers typically stay consistent over the life of our plan, and we do maintain a 5-year plan cycle. We work with the board on this area of the framework through our strategic planning process. We concluded these efforts back in the spring of 2022 with the board's approval to implement our current plan in place that goes through 2027 and the measures that are in place today. So the bottom layer of this framework is related to those business plan initiatives. These are determined by our internal team across the organization, and they articulate the work or the projects that we're going to undertake this year to help us achieve our goals and objectives along the way. Our business plan is refreshed each fiscal year to adapt to our changing environment, to help us mitigate any barriers, and to ultimately stay in pursuit of our mission and our vision. We do kick off a refreshed business plan at the beginning of that fiscal year in July. And as I mentioned, as part of your materials, you have a copy of the plan. So about 9 years ago, when Marcy first came on board, she shared her vision with us about the importance of measuring organizational performance and ensuring the effectiveness of our processes. And with that inspiration, we established what we call the Enterprise Performance Management System. And although I do refer to this as a system, it is not necessarily a technology platform, but a formalized framework of our people and our processes that help us maintain the integrity of our goals and our expectations. The intent of this system is to reinforce CalPERS' desire to be transparent and accountable, and the system supports the board's oversight role into our strategic priorities and overarching operations. Excuse me. We do provide quarterly reports and dashboards of our progress within the Insight tool directly to our board. And this system also provides visibility for our stakeholders. We know that they care very much about what we're doing in our day-to-day business and the strategies that we have set forth. So all of our reports are also posted via the CalPERS website. Each of our executive owners own several indicators that represent our team's work across the organization, which gives us a very comprehensive view of our progress. So here we have the view of our 5 strategic plan goals, and I'm going to hand this off to our executive team now to take you through each one of these. And first to kick us off is Stephen Gilmore with pension sustainability.
Thanks very much, Sabrina. Pension sustainability is a shared goal, shared, I guess, across all of us, but specifically it's the Finance Office, the Actuarial Office, and Investment Office that focus on this. The primary tool for achieving pension sustainability is to generate strong returns without taking excessive risk. And the main vehicle for doing that is our asset and liability management exercise. And we've been going through that for the best part of a year now. And the board will have important decisions to make, especially in November, on that. Of course, the aim is to generate those high returns and to improve the funded status of the portfolio. And you heard yesterday that the funded ratio narrows up to 79%. What I would highlight is not so much just that number, but the trend. And Marcy talked about just that improvement over time. It's not going to be a straight line. I think focus on the trend. It's steadily improving. That's what's important. And we need to focus on that long-term objective. The stronger the returns that we have, the more beneficial it is for our members. It keeps those contribution rates down, and it just ensures that we do have that pension sustainability. But I also wanted to talk a little bit about some of the other components rather than just the pure return and narrow measures of risk. One of the things we do think a lot about is resilience of the portfolio. And one of the big initiatives we took was SI, so that's Sustainable Investment 2030. Because the world's changing, and you heard yesterday from Adebayo from GIP about just how large the investment opportunity is in the energy transition space. So we have, I guess, an ambitious target of increasing our funding to sustainable investment in the climate-related space. We aim to invest $100 billion in climate solutions by 2030. I see this as making the portfolio more resilient, but also, as I mentioned, it's such a fruitful area of potential investment opportunity. So it's kind of twofold. Also, we had a presentation yesterday on emerging managers. I like to think that is not only contributing to the near-term returns, it's about finding those future managers that will contribute to the portfolio through time. One of the other things we're doing, and this is a large-scale effort, is to improve our data and technology. You've heard presentations on AI and the importance of actually having quality data. It's the same thing for the portfolio. One of our real strengths should be all the contact points we have, all the data we have, but we need quality data and we need to be able to analyze that. So we're going through a major exercise to improve our analytical capability, to improve our data, And it's sufficiently important that both Marcy and I are co-sponsors of this initiative. So you'll continue to see more on that through time. The other thing I wanted to point to, and I'm really, I don't want to emphasize this too much, is just how we're going with our asset and liability management approach. Almost every investment committee meeting we talk about it. But the idea here is to try and perhaps be a little bit innovative, to be closer to the forefront of the investing industry. There is a major trend away from the historical approach of strategic asset allocation, which tends to be somewhat more anchored to a total portfolio approach where you're thinking about the whole. And conceptually, that sort of approach should generate higher returns. Based on the data we have, it has done that, but it's not easy to implement. What it requires is a lot of collaboration across teams. And a lot of the things we're doing internally focus on improving that collaboration. It also means getting the data, and I've talked about that just a little bit before in terms of the data and technology initiative that we are engaging upon. It's also very important to have a clear understanding of the risk, and we've talked about that before in terms of the board's risk appetite. And again, incredibly important to be thinking about the long-term horizon. The other thing I would add is really important to focus on the advantages that we have as an institution. One of those is our size. Sometimes that can be a disadvantage because sometimes the investments are just too small. But one of the big advantages is it allows us to negotiate better. It also means we can be the most important partner for a lot of our managers. And you're seeing that in some of the asset classes. You've obviously been seeing the success of the private equity portfolio. So we've used that advantage in terms of size. We've used that advantage in terms of our name recognition and also our long horizon. Our long horizon allows us to look through the ups and downs and to harvest those potential returns, hopefully from not being cyclical, but being steady through time. And I think that's something you see in the private equity market right now, where some of our peers are potentially pulling back. I think that provides an opportunity for us as a long-term investor. I talked about collaboration, and one of the really important collaborative efforts we've embarked upon is our interaction with our colleagues in our human resources team. We have a number of shared objectives. We want to improve succession planning within the organization, and Michelle and I are working very closely on that across the investment team and the enterprise HR team. We're also looking at development in terms of growth for individuals, and obviously if we develop our people, they become future successors. The other initiative that I would sort of point out is how we're working on ourselves in terms of the leadership team within the investment.
Two? Yep. Temporary outage.
So, welcome back, everybody. Apparently, there was a temporary outage in all of Monterey. We had a power surge, so hopefully we will sustain ourselves for a little while longer. Otherwise, we might end up on a generator. So I'm going to throw it back over to Mr. Gilmore so he can finish his presentation. And thank you, everyone, for being patient.
Thank you very much, President Taylor. I was talking about how the leadership within the investment office was investing in itself with the aim of improving collaboration. And this is a joint effort between the investment team, our partners in HR. We have specific business partners within HR, and also UC Davis has been helping us with that. The intention is to roll that process out to more of the team through time. So it's really a feedback exercise to try and improve that collaboration. The other thing I'd highlight is something we're doing to help or encourage development of our high potential people. So we've embarked upon a secondment program that has the advantage of obviously giving those people exposure to other areas, but it's also something that we want to encourage as we move more towards a total portfolio approach. So people aren't siloed, so they see other areas, so they work with their colleagues. And so far, the initial signs from that program have been excellent. So it's something we want to foster more. And with that, I will pass over to Don.
I'm afraid to touch that now, but I will anyway. So I'm the way I'm going to tackle this. I'm going to talk at a pretty high level about the tools we use to reach our strategic goals, and then I'm just going to provide a couple of examples. The things that we do often touch upon multiple different goals, and I'll explain why in just a second. So I think it works better this way. If it doesn't, I apologize in advance. So the health program's core strategic goal is to provide exceptional health care to our members. We do this by ensuring access to high quality, affordable care for those who we serve. Through our strategic initiatives, we have committed to realizing that exceptional health care by promoting clinical quality and health equity, and by ensuring that our benefits are accessible and affordable. The most powerful tools we have for accomplishing our goals and the supporting initiatives are by far and away our contracts. Contracts underpin just about everything we do. They lay out the benefits we offer to members, the expectations we have of health plans and managers of our pharmacy benefits, our costs, and our quality and equity initiatives. Our contracts are powerful because we are a very large purchaser of healthcare, the second largest purchaser on the U.S. commercial market. So we're in a much better position to reach strong terms through them. Our sophistication also drives the strong terms we're able to negotiate. In contracts, we have professional team members who follow, who understand the U.S. healthcare system deeply, understand how health systems in other countries work, and they keep up on all of the trends that generate changes to that system. So we use that to our advantage as well. Increasingly, our partnership with Covered California and the California Department of Healthcare Services has made our contracts even more powerful. We've used that partnership to transform markets and to do collectively what we couldn't do on our own. We're still somewhat early days on tapping the possibility here, but I can't underestimate the opportunity it presents. I've said this before, but the three entities together provide healthcare for 43% of California. That's 18 million people. This means that when we're able to align on a change to healthcare, and when our incentives are appropriately powered, the healthcare market has to respond. We've seen this with the quality initiatives that Dr. Logan has talked about, and we're starting to see it in some other areas as well. Another important way we realize our goals is by being a learning organization. We have a small but mighty research team and one of the most powerful data resources in the country. This combination allows us to choose the initiatives that are most likely to change the trajectory of healthcare for the better, but also to see whether those changes are doing what they're supposed to be doing. We are evaluating all of the big changes you've been seeing over the last few years, using a population health entity, Included Health, as a point for our PPO member interactions, a financial alignment that we now have in both our PPO and PBM relationships, and the quality and equity incentives we've added to our contracts along with Covered California and DHCS. Doing this means that, that we and you will know if these and other critical initiatives are working, and it will allow us to make the micro level adjustments necessary for them to continue working. I'll add one more thing before I turn to the few initiatives that I wanted to highlight. Of all the advantages CalPERS has as a healthcare purchaser, its size, its strategic partnerships, its sophistication relative to other commercial purchasers, its most significant advantage is its members. More specifically, it is that CalPERS members stay with their public sector jobs for a very long time, many of them for most or all of their employed lives. That, combined with the fact that we have many second and third generation CalPERS members, and the fact that we offer family and retiree coverage, means that investing in the health of our members is also the right approach from a financial perspective, particularly over the long term. Investing in prevention, our population health approach, and good primary care improves our bottom line because there is a high probability that we'll be providing care for them for many years, and even as retirees. This is extremely atypical for other commercial purchasers, where employees move in and out of employers every few years, and where retiree benefits really are non-existent. With all that said, I wanted to provide a couple of examples of how this plays out. The first one is our pharmacy benefits contracting effort. Julia gave you an overview of this morning. The new contract and the due diligence the team did over the past year to secure a strong and innovative contract for the next 5 years for our self-insured outpatient prescription drug benefit. I don't want to belabor all of that, but a couple of things to highlight and how they relate back to the strategic plan and our strategic goals. Our goal of going into the process over a year ago was to make sure the contract and our relationship with our vendor reflected our own strategic goals of affordability, access to medications, transparency, and quality. With the new contract, we've accomplished this through the performance guarantees, which drive accountability, the cost trend guarantees, which help ensure financial predictability over the course of the contract. I also want to emphasize the importance of additional layers of transparency, including audit and oversight provisions that are in this new PBM contract. The other area I wanted to highlight, again, Dr. Logan and Dr. Albers talked about this morning, but I wanted to talk about how it relates back to the strategic plan, is behavioral health. As we've talked about before, behavioral health remains an area of focus for us and across California because it's such a statewide issue. It's one we're leveraging our partnership with Covered and DHCS over the next year. As Julia noted, we're working with them through the Office of Healthcare Affordability on behavioral health spending benchmarks, which will guide our investments in behavioral health care, ensuring resources are allocated effectively to meet our member needs. I'm particularly excited here about the Secret Shopper study that Julia noted. It's really one of the only ways of having a lens into what's really going on in real life. It's something that I had tried to do at the federal level during Obamacare implementation but it's something that that you see very infrequently because it is plain data that you can't hide from. So we will be sharing those outcomes with you. We will be using them to put pressure on our health plans to make the changes that are necessary. And I'm really appreciative of all the work that went into setting it up. The last area I wanted to talk about today was primary care. You all know that we have strongly supported primary care. We're appreciative of your support of our primary care approach. I don't have to remind you that high-quality primary care is critical for improving population health outcomes, reducing disparities, and slowing healthcare cost growth. This coming year, we will continue with that commitment as we look to enhance our primary care investment to drive healthcare affordability and quality. We are amending our contracts to meet the Office of Healthcare Affordability requirements around increasing primary care spend, and are working with plans to build this infrastructure, like our work in behavioral health. It's very weedy work. It includes measuring and standardizing primary care spend and developing alternative payment models to support primary care investments, which are necessary for long-term innovation and improvement. Together with Cover California and DHCS and other stakeholders, including the California Healthcare Foundation, we're hosting a meeting in November with plan leaders to think collectively about how to support further investment in primary care. On Friday, CalPERS, with the executive leadership of Blue Shield and Included Health, are looking at how we further primary care development in our PPOs. As part of that meeting, we'll be discussing our joint primary care charter. The charter describes and reaffirms the commitment of all parties to a primary care-centric approach for our PPO members and describes the steps we are committing to making to move all of those efforts forward. So those are a couple of things that that bring together some of those approaches. And with that, I will turn it over to Michelle.
Thank you, Don. All right, and thank you, President Taylor and board members. Michelle Tucker, CalPERS team member. I'm very excited today to share with you our approach to organizational excellence. This is a framework that is central to our strategic goals and essential to recruiting and retaining top talent. It also plays a key role in enhancing the CalPERS team member experience. Of course, we're very grateful for your insights as we present this and tell you a little bit about what we've been up to. Today, I will speak to the strategic work that we're doing around our enterprise engagement results and the progress that we're making through our recruitment campaign. So let's start with the team member engagement. In April, we shared some results from the CalPERS annual employee engagement survey. I'm pleased to report that nearly 3/4 of our team members, 74%, participated in the survey, providing valuable feedback on how we're doing as an organization. This level of participation reflects the commitment of our team members to shaping a better workplace. This year, we took an exciting step forward in our engagement strategy. In addition to the team leader action plans that we've always developed, we introduced a new element to our approach, leveraging the insights and fresh perspectives of participants in our Emerging Leader program to positively impact future survey results and overall engagement. Our Emerging Leader program is a 6-month cohort designed for journey-level team members who aspire to take on leadership roles. Through this program, participants gain critical skills, exposure, and knowledge that prepares them to compete for future leadership opportunities. One of the key components of the ELP curriculum is a collaborative project. So participants are divided into teams, and we do use Strength Finder assessments to divide those teams. And they are tasked with researching and developing recommendations to address real business challenges at CalPERS. So this year we did something different, and we enhanced our project approach by focusing all of the teams on a single enterprise strategy, which is driving employee engagement. The ELP teams tackled key opportunity areas identified in the employee engagement survey, including the valuing team member contributions, enhancing communication, fostering a stronger sense of belonging, and ensuring efforts are made to gather team members' perspectives. To develop their recommendations, participants used innovative research methods such as cafe corridor surveys. They used both QR codes as well as paper. They had focus groups. They interviewed division chiefs and regular leaders, and I shouldn't say regular leaders, all leaders, but they interviewed all levels of team leaders and team members, and they compiled that research into best practices. They looked at both what the various public and private sectors were doing. And then in June, our emerging leaders presented their findings and recommendations to the CalPERS senior leadership team. Their presentations were truly inspiring and showcased the creativity, thoughtfulness, and dedication of these 25 aspiring leaders. And it really was a remarkable session. We had the executive team and our senior leadership council were there. It truly was inspiring. Two particular ideas I thought I would share as kind of a sample of what they came up with. One team proposed creating a centralized team information hub on SharePoint, and this hub would provide resources for recognition, training, team development, and manager support, addressing the survey statement, "I feel valued as a member of the CalPERS team." Another team focused on improving efforts to gather input from all team members, and they recommended developing an empowerment toolkit, which would equip team members with resources to foster stronger relationships, facilitate feedback, and support effective follow-up. But the true value of the Emerging Leader Program extends beyond the projects. One graduate shared that her greatest takeaway was the relationships she built with fellow emerging leaders, mentors, project sponsors, and subject matter experts. These connections are vital for fostering a culture of engagement and collaboration across CalPERS. The CalPERS team is currently evaluating the recommendations presented by the ELP groups to assess their feasibility and impact. We aim to begin implementing select initiatives later this summer, continuing our commitment to improving team member engagement and supporting the growth of emerging leaders. As we continue to focus on creating a workplace where team members feel valued, engaged, and motivated, it's important to recognize that this commitment begins well before someone actually joins our team. Our recruitment efforts are designed to attract individuals who align with our values and culture, people who thrive in a collaborative, mission-driven environment. So let's shift our focus now to our recruitment campaign and outreach strategy, which directly supports our strategic goal to establish an outreach strategy. This work goes beyond filling vacancies. It's about building a talent pipeline that has diverse, skilled, aligned team members, people who are aligned with our mission and our values, who reflect California, to serve the members, employers, and stakeholders at the highest level. Before diving into the numbers, I want to quickly revisit what we set out to do. We had two primary goals. First was to close the vacancy gap by actively addressing open positions and ensuring that CalPERS has the talent that we need to thrive. And the second was to increase qualified applicants by attracting skilled, mission-aligned candidates who reflect the diversity of the communities we serve. Our first large-scale recruitment campaign, where passion meets purpose, has shown real traction. We delivered over 13.8 million impressions across platforms, plus 2 million in bonus placements, boosting awareness at no extra cost. We attracted new interest. 96% of website traffic came from first-time visitors. So that's a major sign that we're reaching some really untapped talent. We also prepared a channel performance snapshot, which summarizes how specific marketing and advertising platforms performed. A few highlights. Google Search was one of our best performing tools, delivering a 16.8% click-through rate, which is well above the 5% goal, with strong performance around things like state jobs, public service career. On LinkedIn, we reached talent pools and operations and entry-level roles, and we had one of our Invo team members, Jeremiah, and the Jeremiah GIF ad alone drove a third of LinkedIn clicks. So shout out to you, Jeremiah. YouTube viewers also were very well engaged, with 1 in 3 watching our recruitment video to the end. And we also ran 380, almost 500,000 LED billboard spots across Sacramento, which really helped to raise brand visibility in our home region. And I know a lot of people really enjoyed driving around the highways and seeing our team members. And our display and video ads brought over 1.1 million video views, building further awareness. In addition to the increased attention on our digital channels, we also noticed that users were interacting more with the CalCareers site after clicking on ads from other sources. The job openings and exam page was the top destination with over 8,000 views, which is a really good sign that people were actually exploring roles. And other frequently visited pages included how to apply and job fairs and events, reinforcing that the content is relevant and effective. So in terms of outcomes, we want to do a year-to-year comparison. So this strong engagement with our website content sets the stage for what we saw next, a clear increase in applications this year compared to previous years. Our recruitment campaign data provides a snapshot of applicant activity for February and May 2025 compared to the same time the prior year, the prior year. Our recruitment campaign data shows that applications are up 50% compared to the same spring period last year, from about 8,600 in 2024 to 13,000 in 2025. For our largest job categories, Staff Services Analyst and Associate Governmental Program Analyst, we saw an even bigger jump, a 72% increase in applications. For the Investment Officer Series, we saw a surge of 194% increase in applicants. Hiring pace has remained steady with 198 hires in 2024 and 197 hires in 2025 for the same time period, showing that we're maintaining the hiring even though we have dramatically more qualified applicants. We also did see some shifts towards external hiring. We're now at about 52%. So that tells us that our external outreach efforts are indeed working. As we expand our reach, we're also advancing our commitment to building a workforce that reflects our communities that we serve. Applicants identifying as LGBTQIA+ increased by 8% overall and 10% among SSA and AGPA roles. For investment officer applicants, we saw a year-to-year increase of 66% in applicants identifying as LGBTQIA+. We also saw an increase in applicants who checked the box identifying how they identify in terms of their sexual orientation, which is something that we're very pleased to see. In the past, folks had often just declined to state, so that's very positive. Applicants with disabilities increased by 24% for those same classifications. For investment officer positions, applicants with disabilities increased by 13%. We saw an increase in 37% with our veteran applicants. And although generational cohorts such as Generation Z or Gen Z can't be directly measured, we did see increased applications from folks in younger age groups. Specifically in the Investment Officer Series, the percentage of applicants under 39 increased significantly from 48.4% of the total applicant pool in 2024 to 63% in 2025. This shift reflects a growing interest in the series amongst younger professionals. And also we saw a notable increase in applicants that are aged 21 and under. So we are seeing that we are having a combination of the 21 and under and 21 and 39. So we know we're impacting Gen Z and the millennial population. While our digital outreach certainly broadened the diversity of applicants, our career services and outreach team played an equally important role. This team engaged with over 2,200 candidates through 21 outreach events, including career fairs, CalPERS hosted events, and workshops. From those efforts alone, we saw 228 job applicants and 27 direct hires, which is a really strong return on that relationship-driven recruiting. Whether it's a career fair table conversation, a candidate workshop, or direct sourcing, these efforts are delivering a steady stream of qualified applicants into our hiring process. As Stephen mentioned earlier, we're very excited to partner with his investment team on the people and culture initiatives. We're working across the enterprise to align workforce planning and succession strategies with the CalPERS strategic plan, which includes using data-driven forecasting tools, identifying critical roles and future talent needs, and recognizing potential successors and talent pipelines. Together, these efforts will help us build robust career progression pathways, strengthen leadership development programs, and support a diverse, skilled, and future-ready workforce. So that concludes my portion of the presentation on organizational excellence from the people perspective. So thank you very much. And now I'd like to turn it over to Stevenson Levson to walk us through key initiatives and opportunities to enhance our digital capabilities.
Thank you, Michelle. Good afternoon, members of the board. Thank you for the opportunity to provide an update on our Generative Artificial Intelligence, or GenAI, business plan initiative. This initiative was established as part of a broader business strategy to evaluate how GenAI can enhance our processes, create efficiencies, and drive innovation across all areas of our organization, including customer service, health, investments, and information technology. Today, I'll share the progress we've made, the tangible outcomes we've achieved, and the exciting opportunities we are preparing to unlock in the coming year. Over the past several months, we've made significant progress in laying the foundation for responsible and impactful adoption of GenAI across the organization. We conducted a comprehensive evaluation of our organizational readiness for using GenAI. This assessment covered areas such as governance, policies, security, infrastructure, data, and readiness of our team members. Based on the assessment, we've updated our acceptable use policy to align with industry guidelines and best practices. This has ensured that our approach to GenAI is secure and responsible. We developed a strategic roadmap that outlines our vision for GenAI adoption, prioritizing initiatives that deliver high value while minimizing risk. To ensure proper oversight, we established an AI governance framework. This includes the creation of an AI governance committee, which oversees all GenAI related activities and ensures alignment with organizational goals. We also published Responsible AI for Public Professionals training to build awareness and equip team members with the knowledge they need to work effectively with GenAI tools. We've successfully piloted several AI use cases, including Percy, our very own GenAI assistant, which has demonstrated the transformative potential of GenAI. Looking ahead to the next year, our focus will shift towards scaling adoption, deepening organizational readiness, and unlocking new opportunities. Now, a little more information about Percy. Percy is CalPERS' innovative AI assistant designed to boost team member productivity and foster creativity within a secure environment. Percy can draft documents, emails, and presentation content on a wide range of topics, from project plans and notes to member communications. It also excels at analyzing and summarizing text and images, enabling users to quickly process large amounts of information and compare multiple data sources. The release of the tool to the enterprise has empowered CalPERS team members to focus on strategic priorities and deliver exceptional results using GenAI. Now, I would like to highlight a few of the exciting use cases we're preparing to launch in the upcoming year. PearlBot is an AI-powered solution designed to streamline the analysis of labor policy language for compliance with the Public Employees Retirement Law, or the PEARL. So as you know, our PEARL is 1,300 pages in length, over 1,300 pages in length, and contains very important information for us. I bought the PEARL for you with reference, and I'm pretty sure you all read the PEARL. This tool will significantly reduce the time and effort required for policy analysis while ensuring accuracy and compliance. Microsoft 365 Copilot is an AI-powered assistant embedded in the Microsoft suite of products that will enhance productivity by generating content like emails and providing intelligent suggestions and summarizations across applications like Word, Excel, and Outlook. We are in early pilot phase of the rollout and assessing its impacts and benefits. For the investment office, we are actively looking to extract and analyze large volumes of unstructured investment research data from various sources and provide insights utilizing the power of GenAI to enhance our data processing and analysis capabilities. The contact center summary use case leverages AI to automatically generate concise post-call summaries of customer interactions. By reducing the time agents spent on post-call notes, we can improve productivity and enhance the quality of our customer service. Within IT, we are looking to see how GenAI can enhance our software development lifecycle by assisting in analysis, coding, and testing efforts. By leveraging GenAI's advanced capabilities, we aim to streamline the entire development process, ensuring more efficient and accurate outcomes. GenAI represents a transformative opportunity for our organization. By leveraging its capabilities responsibly and strategically, we can drive innovation across critical business areas. The progress we've made so far is just the beginning. With the initiatives planned for the coming year, we are well positioned to unlock the full potential of GenAI and deliver meaningful value to our stakeholders. Thank you for your attention, and I look forward to your questions and feedback. Now, I would like to hand over to Kim Mom to talk about member service enhancements.
Thank you, Stevenson. I thought I would start with the member service commitments that we've accomplished already in the strategic plan from 2022 to now. And so that's this first page that you'll see. First, we've added functionality for members to apply for disability retirement and survivor benefits online. This was implemented in August of 2024. We also added functionality that provides members with access to communicate confidentially with us online, in addition to allowing members to upload additional documents such as trusts, birth certificates, and marriage certificates. And as you're aware, we implemented a class on planning your retirement basics in Spanish in 2024, which is now on our YouTube channel. On June 24th, so just recently, we presented our most recent addition to our Spanish class offerings, Basics of Your Retirement Application and Beyond. Moving on to process improvements. We've made some improvements to the benefit verification and overpayment areas. You may recall from my June board meeting update that we kicked off the 2025 benefit verification cycle in March. This process is now conducted annually to prevent overpayments due to unreported member deaths. We also implemented SoCure for death notification. Through this tool, we have found 512 deaths since the implementation in 2024. Because of our efforts in overpayments, although there was $127 million of death overpayments for new deaths in 24-25, we have already collected $118 million so far, or 93%. We've also collected another $6.6 million for overpayments that remained from prior fiscal years. All of these efforts that we did last year that I discussed with you guys on our overpayments projects are now coming to pay off with our immediate collection efforts. Our next area of process improvements is Computron. Computron is an improvement that we implement as a generative AI tool, and it performs compliance reviews of labor agreements and MOUs for our employers. Currently, employers will submit written questions to our employer division, and the analyst spends time reviewing their MOU, publicly available pay schedules, labor code, the PEARL, and checks compliance with relevant statutes and regulations. Computron now does this for our team in moments without having to read the long MOUs and comparing them to the PEARL. It then automatically writes the response to the employers with the issues identified and suggested language to make the MOU compliant with the PEARL. Testing will continue on this product into 25-26 to identify any gaps, look at other areas that this can be used to improve daily processes, and as well as develop training and quality assurance program. And then my last area for process improvement is we've transitioned the knowledge management system, My Expert, to that replaced My Info. And this was a tool that the call center and our regional offices use to answer member questions. So it's a very important part of our business and was a major upgrade for access of information, searching capabilities, and content management. Moving to compliance. On January 1st, 2025, the Office of Administrative Law approved an amendment to Regulation 574 to clarify how school employers should report full-time equivalent pay rates for classified employees. Full-time is officially meant 40 hours a week since the year 2000, but this amendment broke down how to calculate and report those pay rates when earnings aren't based on a 40-hour work week for schools. We also developed an online calculator to help these employers easily perform the calculation anytime. We also refreshed our guidance for school employers about hiring retired annuitants. What we wanted to make clear is that schools can hire RAs for temporary work of limited duration, such as subs, bus drivers, food service workers, and yard duty workers. This clarification was extremely important to our school retirees and employers. We also added a questionnaire on our website to make it easier for schools to stay compliant. So I'll move now to what's up this next year that we're working on. For the survivor benefit accounts, we're now looking ahead to this next fiscal year on two major areas, the member and employer service enhancements and process improvements. The survivor benefit self-service page is one of the first ones that we'll be working on. These updates aim to make the content clearer and more user-friendly, helping beneficiaries and survivors that are receiving monthly benefits to understand their benefits, manage their account, and keep their information current. Another self-service enhancement on the horizon is a new online tool that would allow employers to register local safety disability determinations directly in CalPERS, which will save time and simplify these submissions, how these submissions are made. It also allows our employers to track the status of this being updated. Next, we'll continue our work with educating employers and retirees on utilizing retired annuitants. We will be developing enhanced training on working after retirement and a tailored training video for schools, public agencies, and state employers to ensure compliance and streamline the process. In addition, each division within CSS has a project this fiscal year to encourage more members to register for CalPERS accounts. This not only helps them manage their benefits, but improves communication and helps the security of their account. Starting with CEOD, they are going to automate targeted outreach to get members to create a CalPERS account prior to their regional office appointment. This will help streamline their appointments and reduce setup time, allowing more focus to answer member questions and not time spent on creating this account. Additionally, they will develop strategies for those with limited computer access. In the call center, agents will check if members have a CalPERS account when receiving a call and advise them to create an account before appointments, providing setup instructions. In the Disability and Survivor Benefits and Retirement Benefits Division, they will be developing dashboards to track and analyze CalPERS registrations, to identify trends, measure outreach efforts, and develop strategies to increase CalPERS registrations. The Employer Division will highlight benefits and security of members having CalPERS accounts at key employer events such as CalPERS Education Forum, including having an exhibit at the forum. We're also going to explore employer-initiated CalPERS accounts when there are new hires for each of the employers. In member accounts, they know that inactive members are hard to reach, with 458,000 of the 551,000 inactives not vested. To improve outreach, they will use the product Clear to update contact information, promote CalPERS registration to inactive members, and collaborate with employers to update details at separation. Finally, we're enhancing self-service tools by adding a COLA and a tax withholding calculators, making it easier for our members to get the information they need on their own without having to call in. Our goal for those two tools is for 25-26. However, it could shift to 26-27, depending on resource capability. Moving to process improvements, we're going to leverage technology, as Stevenson mentioned, specifically to Gen AI to improve processing and hopefully make work easier and more efficient for our members and our team. For example, we're taking big strides to improve how we participate or how we do participant notes. In the contact center, we will leverage the Gen AI to summarize phone calls, which will save agents time and ensure accurate notes. We'll also begin tracking the types of calls we're receiving and hopefully help some of the business areas with communication. In our regional offices, we'll utilize Gen AI to summarize the participant notes in advance of members' appointments. This reduces the need to manually review all notes beforehand and will help improve the member experience and keep the appointment on track. And for service credit purchase correction cases, we'll also summarize participant notes. It will streamline our ability to search for and identify relevant information tied to the correction and accelerates the creation of the summary of events to document the correction. This reduces manual review time and ensures greater consistency in how case details are captured and presented. We're also looking at how Gen AI can improve document summarization, not just participant summarization or participant notes. An example of this is medical documents. Right now, medical documents for disability retirements come in from doctors that are 50+ pages. Doctors don't want to summarize those reports on our 3-page form. So either the employers or our team members have to take those 50-page documents and try and translate it onto our 3-page form. And this caused delays and frustrations from our members and from our employers. So we're hoping to use Gen AI to summarize the information on the doctor's detailed medical report and transfer it onto our form. Gen AI can also help us with reviewing documents like community property and other legal court orders. It could review and summarize key provisions to determine if they meet legal requirements for dividing pension benefits as defined in the Pearl and family law. This would allow us to simplify a complex process while improving both accuracy and efficiency. All of our goals and the goal of all of our efforts is to improve our experience for our members and hopefully, as a side benefit, reduce the number of calls we receive to the call center. This concludes my comments, and I will turn it over to Brad with the clicker.
Thank you, Kim. Good afternoon, everyone. Brad Pacheco, CalPERS team. I'll wrap up our highlights here by providing some updates on advancing 2 key objectives related to stakeholder engagement. The first is providing ongoing education, making sure our stakeholders are kept informed about system impacts, policy changes and risks, and then enhancing our communication tools or adding new tools so we can better support our members and employers and stakeholders. During the year, we did introduce a few new channels. CalPERS Now is published quarterly. It provides insights into our key priorities. This is in addition to our monthly Perspective member newsletter that goes out to all members, and it serves as a good vehicle to address our views on current policy issues. We also introduced our Retiree Town Hall with Ms. Walker, which has served as an opportunity to connect directly with our retirees, answer their questions, and provide clarity on important updates. And we usually have about 600 to 800 retirees participate on a quarterly basis. On the digital side, we've made some enhancements to our website to enable us to communicate more clearly and make it easier for stakeholders to find what they need. In May, we worked with Stevenson's team to add multi-language capability where members can translate the site into different languages. We're seeing that being used with the top 5 languages being Spanish, Chinese, Japanese, Korean, and Portuguese. And our in-person outreach efforts have been extensive. We've engaged with our stakeholders at over 160 events this year. That's a lot of conversations, and it's been invaluable in building stronger connections. I did want to talk a little bit about our email communications because that is our primary tool to reach our members. Here are a few quick stats. In the first 5 months of this current calendar year, we sent out 122 communications. That's a 23% increase from the same time period in 2024, with a total of 23 million emails. We're seeing a 98.9% delivery rate, which is excellent. That means that Kim's team is keeping accurate information in the MyCalPERS system. Our open rate is over 37%. It's well above industry standards. In some of the reports that you've received in the past, you may have seen open rates in the 40% range. It has decreased slightly simply because we're more precise about the data we track. We've removed NHI data, which is non-human interaction data. There are programs that simulate opening emails for security reasons, and so we've removed those from our data just to be more accurate. And our opt-out rate is just a fraction, a clear sign that people value the information that we're sharing. So looking ahead, we have some plans to build on this momentum. We're working on accessing more MyCalPERS data to deliver even more personalized and relevant communications to our members. We're hoping to implement a lifestyle approach for email communications. This means automating emails based on specific triggers or milestones in a member's career so they get the right information at the right time. On the website front, we're partnering with IT to explore a full redesign in partnership with an external vendor. The goal is to create a more modern and effective communication platform. And then finally, we're taking a closer look at our social media presence, analyzing our growth and engagement so we can better align our messages with the audiences on each platform. And we will, it's not included here, but we are exploring the idea of a podcast for CalPERS and working through that to see where we can benefit from that channel. So in closing, we're proud of the team's progress. These efforts are all about strengthening our relationship with stakeholders, making sure they feel informed, supported, and engaged. And with the plans that we have for the future, I'm confident we'll continue to build on that foundation. So I'm going to turn it back over to Sabrina to close us out.
Very good. Thank you, Brad, and thank you to all of our panel. There's definitely a significant amount of work going on within the organization in alignment with our strategic goals. And so now looking ahead, the CalPERS team will plan a thoughtful project management approach to planning for our next strategic plan. We want to ensure full engagement from our internal and external stakeholders and have enough time to discuss, vet, and finalize each element of developing all of those layers I reviewed earlier. So the goals, our objectives, our measures, and our initiatives, which a 2-year planning cycle helps us achieve this. As you can see from the timeline, we recently concluded the project initiation phase, and we're kicking off planning with you here today. With this planned approach, we anticipate a timely execution of our comprehensive 5-year strategic plan ready for implementation by July of 2027. Of course, this perfectly aligns with the ending of our current plan that's in place. As you can imagine, there are many steps and activities involved in preparing behind the scenes, data gathering, analysis, as our goal is to be as thorough as possible. We will include board and stakeholder engagement opportunities to discuss important topics and gather feedback throughout our process. Next slide, please. So more specifically, here are some highlights of what we have planned for board engagement over this time horizon. First, over the first fiscal year, we're going to really be focused on gathering feedback, conducting our current state assessment, our environmental scan, and analyzing our trends. So during this first quarter of the current fiscal year, we want to meet with you directly, listen to your insights through small group interviews, gathering your feedback as part of our SWOT analysis. So what's your point of view on our strengths, weaknesses, opportunities, and threats? And we will work with the board services unit to coordinate this effort. We'll then bring all of these findings back to you in summary and share the themes that have emerged and our proposed first cut of goals and objectives for you to consider based on our analysis. This will be brought back to you next July, which is not that far away, to further our discussions and continue to refine and vet the goals and objectives based on those discussions and follow-up. And then next fiscal year, post July of 2026, the team will be focused on refining based on your feedback and then using this information to develop our set of proposed measures. And when it comes to our measurements, we understand we have a great opportunity to take a step back, to reevaluate all of our measures, reassessing their validity, and to determine if we have any gaps to ensure that we're focused on the most meaningful metrics. As an organization, I will mention we have matured quite a bit over the past years. In past strategic plans, we did not have very many measures. However, over the past 2 strategic planning cycles, we worked closely with our program areas to develop measures across the organization, to build confidence in our process of measurement, transparency, and reporting. We sought the board's feedback and approval in our measures and the targets and thresholds that are aligned to our measurements. In those areas where we were lacking maturity, it was important to take those first steps and at least start somewhere. And now we have the opportunity to grow and progress further in that development and that maturity. So again, the goal here is to, going forward, really focus in on what are the key measures that we want to have in place to focus on the right things. And we want to have your input on that. So our February of 2027 session will give us a chance to review together again those refined goals and objectives, and then our first cut of those measurements. So we'll consider this our first reading. We will follow up again in April, reviewing again that we have not missed anything, and seek your final approval on our goals, objectives, and measurements. This would be our second reading. And then we hope to conclude that process in July of 2027. We'll come back to one of these sessions, highlight our accomplishments, kind of close out our current plan, discuss any new challenges that we should be focused on, and what are the new initiatives that are going to carry us into the future and have alignment to our new strategic plan, which would be 2027 through 2032. So with that, I will pause here and open up the floor for any questions or discussion items for myself or any of the presenters. Thank you.
Well, thank you, everyone. That was quite the report. Lots of stuff going on. You guys have done a wonderful job over the last few years. We only have 2 left. Well, a year and a half, right? No, actually
Yeah,
2.
2 years.
Yeah.
Our final 2.
Full 2 years, yeah. And thank you for already planning the next 5 years. So we appreciate that. Mr. Palkey.
Let me pull this closer. Thank you, Madam President, and thank you all. I spoke at the last board meeting about the multiple emails that I received from members, school members. And I actually just received one last night, and I'd like to share that with you guys because I think it speaks to the work that you just presented. So I'll redact personal information here, so but I know it'll mean the world to them. Hello, kind sir. Yeah, people refer to me as kind sir. I wanted to let you know the process with CalPERS and my retirement was the easiest thing in the world. I did it all online and never had to make a single phone call. My first check will arrive on time. My partner will be receiving their first check at the beginning of the month. And I made sure to do the survey with all A pluses and making a note of the access online and its simplicity. So again, thank you for everything that you do, every dollar that you solidify in our investments, every dollar that you help save in our health benefits, and every access point that you allow our members to have makes their job so much easier, and it shows in the responses that I get from them. So again, thank you so much for all that you do for us and our members.
Mr. Ruffino.
Thank you, President Taylor. Just a couple quick curiosity question. First one's to Ms. Tucker. Page 14, you talked about the Emerging Leader Program. And if I understood correctly, there's 25 participants. Those 25 participants, just have a question, like the selection criteria, can you self-nominate? Do you get, does somebody nominates you or both? How long is the program? And finally, are those 25 all rank and file or a mix of manager, supervisor, rank and file? Or do you have a particular quota, quote unquote quota, or how the program works?
I am happy to answer that. Thank you for the question, Mr. Ruffino. So yes, our Emerging Leader Program is something we're very proud of. There's a really structured process. So we begin in the fall with a call out for the Emerging Leader Program. Folks have to complete an application package. So we offer sort of like walk-in classes if they want help developing their application package. Then we have a selection committee, which includes folks from our senior leadership level, so like division chiefs, and that group we make sure is representative of our CalPERS team members. Those individuals have masked, anonymized applications that they review. So they review them and they score them. From that, we get a list with kind of like cut point. We have space in the program for 25 people, and that includes some consultation and coursework with UC Davis presenters. It includes a dedicated mentor from the executive team, again, matched by strengths. And then it also includes the project that we talked about. So they talk about the scores. Once that's done, we reveal the names. We do a scan then at that point to make sure that the applications that we receive from the team members are, again, consistent with our team member demographic population. We want to make sure that, there's good alignment there. And so far, we always have had that. So that's a really good thing. And then from that point, we proceed. And they're introduced to their mentor, their mentee. We announce it. They are people who are rank and file. So they are journey levels in their classification. So typically it would be where their next position would be a supervisor. We do ask that folks who are in the program not have been a state supervisor before. So for example, in our investment series, it would be the IO3s. We're going to be adding the IO2s next year. For the more traditional one, it would be an AGPA. So folks like that. And then I think your last question was a quota.
Well, that would be mute point since they're all rank and file employees.
Right, yeah, okay.
I just want to tell you, I think it's a great, it's great, and I'm sure it's working well. And I wish other state departments will take a look at, and do something similar because it's, I think it's a good practice. And at the end of the program, do they get, besides a certificate and hopefully a nice dinner? Or
Well, we don't have a dinner.
No-
But,
no dinners?
We do
Okay.
have a really nice celebration. So this year actually was our return to a first in-person presentation along with a graduation. So they each do about an hour presentation for their group project. And so again, this year we had all of the exec and the senior leadership council watched. Then there's the graduation ceremony. It's really nice. So the mentors and the mentees are there together. We really celebrate it. We're really proud of this group of team members, and we keep an eye on them and kind of monitor not monitor, but we cheer them on from the sidelines. The campaign that we talked about with the folks, with our own team members, a lot of them were emerging leadership program alum. So either ELP or APEX. So I know I mentioned Jeremiah, so he was an ELP alum. And I mean, I think you see the success of that with the click rate. So we're really proud of these team members.
Absolutely. Again, congrats. It's a great program. Just a tiny, tiny little pitch you may want to think about it, including managers and supervisors, either combine them or do something different. Don't forget the managers and supervisors. Another quick question about your vacancy rate. I think it was on page 15,
Yes.
which was great. What's your vacancy rate, Ralph? I don't know. It doesn't have to be exact, but
It can be. I think it's 9.5.
I'm sorry?
I believe our vacancy rate is currently at 9.5 or 9.6. And last year at this time it was 14.7, I believe. So we
Yeah, so that's
reduced it
great.
by 5%.
That's beautiful. Are you keeping any position vacant for salary savings or not really?
I believe we have sufficient vacancies that we don't need to intentionally hold them open for salary savings. So yeah, that's not.
Awesome. One last quick for Stephen. Great job on the training for AI training and and so on and so forth. Any thoughts at all that maybe we could use some of that training for the board, AI training for board members? I just want to put it out there.
So, I mean, let me take a crack at that. So we've looked at a variety of things. I think one of the opportunities is some of the tools that we have sort of made available to pilot with the team members. We could clearly make available. I think it'd be helpful to walk through it or see how it gets demonstrated. But it's a secure environment. It's all behind our firewall. So I think from that perspective, it'd clearly be something we could share with the board in a variety of formats. So something to chat about and see how it would work for you.
Sounds good.
So
Well,
Frank, we just rolled out Copilot, Microsoft Copilot, and Stevenson has been setting up trainings for the executive team, and I'm sure you'll move that through the organization. They have a training course on PERSI, which is operating behind our firewall. So if the board would like to have one-on-one trainings on how to use these tools, we could get that set up.
Yeah, I don't mind get to know Percy a little bit. again, I want to echo the comments previously made by my colleague, Mr. Palkey. Thank you all for your presentations and thank you for the great work. It's always inspiring to hear, all the great things that you guys are doing, especially when we improve. And there's definitely improvements in every single one area. So thank you. Thank you, Madam President.
Access to what?
Pearlbot.
Oh, Pearlbot. Oh. I mean, that's kind of cool because then we don't actually have to go through the book and try to find it. I'm sure it has a word search. There you go.
Yes, it does.
Okay. Anybody else from the board want to ask questions? Okay. Then I have a public comment before everybody goes. But again, I want to thank you guys for your wonderful presentation. Everybody, thank you for doing all of your work. With that, I will call up Margaret Brown, and you'll have 3 minutes.
Thank you. Margaret Brown, Retired Public Employees Association of California. My comment is about member experience. I think Kim might be expecting this comment. And this is specifically regarding school district retired annuitants working back at their old employer. Now, I am a retired school district employee, and I never want to go back to my school district. But for those who actually want to go back and provide services and actually help their school district out and go back and working in their old jobs, for about a year, there was some confusion. It was actually just about a year ago when I got a call from a retired annuitant who had been subbing for several years in the Antioch Unified School District. And all of a sudden she was told that she could no longer do this and that CalPERS had changed the rules. So of course I immediately sent an email to Ms. Malm saying, of course I told this woman she was crazy. That's not true. The rules haven't changed. You must have exceeded 960 or something has happened. And of course that wasn't true. There was just a problem with the circular email that had came out and some communication problems. And it took 1 year, but between Kim and Brad Hansen and the rest of your staff, it got clarified. And I actually heard back 3 weeks ago that she's back in the subpool at her district. She's not the only one. I heard from about 50, but this woman got my personal cell phone. So she got my attention. But I really appreciate all the help and all the work that your team did to get this resolved. It's important to school districts and it's important to the retired annuitants who count on that supplemental pay. Thank you.
All right, thank you. And with that, we are running a bit ahead of time, so I'm going to go ahead and call for our break right now at 2:27. So let's come back 35, 45, 50.
45.
Yeah.
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 Come back when?
No. Yeah. Yeah, 2:45. Could call staff names, so our next session is on cybersecurity and the digital threat to our landscape. Here to kick us off is Al Arboleda, and CalPERS Chief Information Security Officer. He is CalPERS Chief Information Security Officer. He's joined by Serge Jorgensen of Crow LLP. If you're ready, let's kick it off.
All right, thank you. Good afternoon. Today we're going to have a brief presentation covering the current landscape, threat landscape that we currently face, are at in, or I guess in, for 2025. And presenting will be Serge Jorgensen with Crow. He's one of our partners in cybersecurity. I've had a long relationship with Serge over the last 8 or 9 years. Take it away, Serge.
Thanks, Al. Appreciate it. Good afternoon. Just wanted to spend a few minutes, if we could, talking about the current threat landscape that we're seeing from a cyber perspective, and dig into a little bit of the who's doing this, why they're doing it, and how they do it. And would like to certainly be open to directly engaging if you have questions or if there's things we want to dig into further as we go through some slides. But just tried to tee this up with a few concepts covered in the slides. The pictures here have meaning behind them. It's not meant to scare you or anything like that. It's meant to just lay out what the threat landscape really looks like. And the point of this slide is really around the power of a lightning strike. And it's relatively impossible to avoid a lightning strike. Our best hope is to blunt the impact of it. So this isn't in our cyber threat landscape today, and the number of threat actors that are actively out there trying to get into environments for a variety of reasons. This isn't about can we avoid these attacks somehow, but it ultimately becomes Al's challenge and all of our challenges to try to figure out how to minimize the damage and minimize the impact that comes of it. So much like we do with lightning diffusers and lightning rods and all of these things. When we look at the cyber threat landscape and the attack vectors, it's the same concepts. All of the information that we'll talk about here today is really developed over the past 25 years of incident response and cyber intelligence. So when we look at how the threat actors are moving an environment, why the threat actors do what they do, this is all coming from intelligence that we're gaining through incident response globally, whether it's with public companies, state agencies, federal governments, or certainly different critical infrastructure environments. It's taking that knowledge and having conversations and discussions like this, where we dig into the threat landscape and what happens when a threat actor, malicious, state-sponsored, organized crime, whatever, decides to point at an organization. When we talk a little bit about the overall threat landscape, it's hard to avoid what the impact of this is. $9.5 trillion is the estimate in 2024. It'd be the third largest global economy behind US and China if we were to take this as its entirety. So $9.5 trillion. And in terms of the spend that companies are spending on this, $500 billion roughly annually is being spent to try to detect and protect against the threat actors. But when we say why cyber, why are threat actors interested in using cyber to get into an environment? A critical piece there to think about is by 2030, 90% of the world's population is going to be online. What that means, if I'm a nation state threat actor and I'm trying to influence hearts and minds, if I'm trying to collect intelligence about what our government is going to do next, what we're going to do as an organization, if I'm looking for intellectual property, if I'm looking to monetize environment of an organized crime actor, then this is a perfect avenue to get into 90% of the world's population, whether it's through social media campaigns, whether it's through bot farms, or whether it's stealing money from wallets, from bank accounts, or convincing people to buy my product, and snowshoes and Joe jobs and all of those technical attacks that can be levied. In terms of the amount of data, 200 zettabytes, that's 200 trillion gigabytes of information getting created and billions of lines of code getting written every year. So to think that we can somehow protect this information and keep it contained into our computer or our data center is unrealistic. And then with the power of artificial intelligence, of course, and the growing popularity of cyber threats, we're seeing new attacks getting created and launched every 2 seconds. 20 years ago, when I first started working more closely in the cyberspace, you could put a new computer online, plug it into the network, plug it into the internet, and it could sit there for a couple of days before it would start getting detected and attacked. Now today, you plug a computer in, you hook it up to the internet, and within seconds, people are already starting to attack that. So the ability to find new devices and start attacking them has diminished rapidly from the matter of weeks and days into a matter of seconds. Effectively, Google did for the world in a physical world perspective. We used to have maps. You've tried to find a location, and I'm driving here from the airport last night, and I can't imagine trying to do that with a paper map and pulling this out and trying to find roads and everything else. Now I can just type in the hotel address, Google will drive me straight there. So that same technology, the same techniques have taken the cyber landscape and made security through obscurity, the concept of I can be hidden and threat actors won't find me, and throwing it right out the window for the same reason. Google search engines, ChatGPT, all of those ways that we can use to find information, artificial intelligence crawling through data and sites for us, those are allowing the threat actors to rapidly gain access to our data sets and also figure out how to use the data. When I look at the evolution of threats over the last 15, 20 years, if I go back almost 20 years ago now, some nation state decided that, and relevant to current events, decided that Iran was starting to push the limits of their uranium enrichment program. And so in an effort to slow that down a little bit, wrote some malware, some malicious software, and got it introduced into the Iranian uranium enrichment program. And that application was designed to spin the centrifuges too fast and report back to the computers that were controlling the centrifuges that the centrifuges were spinning at the right speed. That causes them to wear out faster, break down a little bit faster, and causes the Iranians to have to buy more of these things, which was hard to do, and the embargoes and everything else, and ultimately slows down the enrichment program. That attack, levied by a nation state, very sophisticated attack, had malicious software baked into it. The problem with, from a nation state perspective, using and developing a sophisticated tool like that and putting it into an enemy environment is that when it's eventually detected, which is what happened here, the Kaspersky, the Russian antivirus company, detected this issue in the Iranian nuclear enrichment program. Kaspersky reverse engineered the malware, and all of a sudden, we saw Iran using that very same malware against Saudi Aramco, who a couple of years later, 2012, woke up to 35,000 computers in their environment with pictures of burning American flags on their screen, with the same malware that was used against the Iranians to slow down their enrichment program. So it's not like a missile where I can fire it in and it blows up and it's really hard to piece back together again and fire back at us. This is a problem that we have in why can't we have offensive cyber operations? Why is this all a defense game? Well, the problem here is that our tools can be used against us, and sophisticated weaponry that's originally designed to be used against a nation state gets turned around and is used to, let's say, attack the city of Baltimore in 2014, 2016 timeframe, and launching ransomware and encrypting malware against the city. So that's the purpose of this image here, is that all of these tools used by the threat actors, maybe developed by a very sophisticated nation state, go into this pool. And then the organized criminals start drawing from those same tools and using those tools against their targets to try to monetize their access into the environment. Once the organized criminals get done using those tools, then they refine them a little bit more, they make them a little bit easier to use, maybe they share them on a dark website, and now we have hacktivists and insiders and anyone that's interested in creating some problems or making some money can go on and Google these tools, download them, and use them to their advantage. So we end up with all of these different attack tools and very sophisticated tools coming at the organizations that are trying to defend, like these lightning strikes from earlier. So it's just an ongoing challenge that we have with the threat actors all pulling their tools from the same environment. And it's really become also over the last 20 years a more formal environment. The hacker, the stereotypical guy sitting in his mom's basement, working on things late at night, slamming way too much Red Bull, out the window. And this is much more of a formalized environment. Some of the organizations that we've worked with over the last few years to take down have had CEOs, CFOs, have had reporting structures, have had sub-organizations underneath them, all tasked with different parts of the attack and different parts of a cyber operation. So the idea that this is not a formal attack anymore has also gone out the window. Most of these attacks are very well planned, very well executed, and the amount of money that the threat actors are making from these attacks is phenomenal. When you look at a recent issue, there was a financial institution here, Coinbase, that had a challenge in that a threat actor targeted some of their insiders and convinced the insiders to give some information up, which allowed access to some of the Coinbase and Coinbase client data. Eventually came back at Coinbase and demanded a $20 million ransom in order to suppress that data. When you're looking at that amount of money being thrown around, it gets very, very hard to think you're going to stay below the radar. One of the groups that we worked with law enforcement agencies in taking down a few years ago was heavy into credit cards, stealing credit cards. And they were making about $50 million a month in stolen credit cards. So it's $500 million organization. And when you look at this is the group that did Target and P.F. Chang's and Jason's Deli and a lot of the names that you would recognize. When you look at that amount of money, if they're trying to get into an environment, they have an R&D department. they can purchase our security tools and our defense tools and figure out ways around those tools. So the threat landscape here has just become more and more sophisticated. Also supported, of course, by the nation states here. North Korea recently attacked Bybit, convinced through some social engineering, convinced one of the people to connect an offline wallet to his Bitcoin account or Bybit account and stole $1.5 billion in cryptocurrency. It's 10% of North Korea's GDP. So GDP, North Korea, 18 billion a year. They stole 1.5 billion in cryptocurrency. Kind of related, the bottom left image there, Hush Puppy, Ramon Abbas is Nigerian. He was arrested recently by FBI in a sting operation. He successfully ran an account takeover, a business email compromise gang for a few years. He was making about 30 million a year in these account takeover attempts, doing invoice rejection and invoice and payroll rejection type events. He was not targeted by law enforcement for that. He was ended up being picked up by the FBI in the sting operation when he tried to help North Korea launder the money that they had stolen. So he was laundering about $200 million for the North Koreans in cryptocurrency, and was arrested, brought to trial in the U.S. Similarly, we're seeing an increase in the blend between cyber and physical worlds. Recently, there was an attack where the Russians were trying to get into Tesla and the Tesla battery factory, and they flew somebody to the U.S. to meet in a bar and bribe somebody to plug a USB stick into their computer at work. To his credit, the employee said yes, went back to the office and told their boss that this has happened and set up a sting operation. And Igor Igorovich is now in a U.S. prison. But the story that he told on arrest was that he was given $1 million by the Russians to come to the U.S. and would get to keep the difference between whatever he had to give in order to get the USB stick plugged in and the $1 million. So you can imagine the rest of that story is if you don't do that, then you get a free trip to Siberia and end up in a gulag somewhere. So highly incentivized threat actors, very well-funded threat actors, and those are the types of things that we are left with trying to protect against and then minimize the impact of when there's an issue. And just something for all of us to think about is when there is an issue, how are we working to minimize the impact and the downstream effects? What's going to happen next after that incident? And is the story, when we look at the protection layers and the things that we've done in the past, is that story reasonable? Have we collected the information? Have we provided the steps to reduce our risk in the meantime to defend against that?
Please feel free to ask questions at any time. Please don't wait till the end. If you have a question, ask it.
Slightly different image than it's on my screen, but so the middle part of this is not broken up like that. But this was an interesting issue from an artificial intelligence perspective. I went into ChatGPT and I asked ChatGPT to make me an image of 6 people in a Zoom meeting, one of which has the Arup logo in the background. And this is what ChatGPT created for me. Relevant because what happened here was that the accounts payable person in Hong Kong from Arup, an engineering firm, they designed the Sydney Opera House and a few other things. She got an email from somebody that invited her to a Zoom meeting. A little bit just sketchy. You know, the company uses Teams, not really sure what's going on here. But when connected to the Zoom meeting, saw on screen 5 other executives of Arup. And they joined and talked through how there was this project going on and they needed help transferring $25 million into 15 different bank accounts over the course of 2 weeks. Started out very suspicious, but you think when you see the people in front of you that you can trust that. And you think that you really are part of an operation that needs to be off the books. So the idea that we can use artificial intelligence, we can use those same tools that we're trying to use to drive efficiency, try to increase our sharing of information, try to make us more functional and do a better job managing our organizations, to be able to use those same tools against us. Unfortunately, technology is neither good nor bad, but it is all about how we use it. So the deep fakes here, the idea that I can take an artificial intelligence engine and use it in a video conference to recreate a voice, to recreate a look of a person, only relying on 30 or 45 seconds of webinar images or public images and public speaking that might be online. So the ability to do this with free or very low cost software has now moved out of the movie production houses and into the grasp of those same organized crime and certainly nation state threat actors we were talking about earlier. What this has led to is a rise of these account takeovers, and those are generally driven by a threat actor looking to get into something, financial information, medical information, whatever that might be, and then figure out how to monetize their access to the environment. So from a nation state perspective, it might be for information collection. From an organized crime perspective, it's all about how can they make money accessing the environment. Oftentimes starting with some mining of LinkedIn, so going out, finding who works for the company, going out to those people, targeting them at home, targeting them at work, and starting this account takeover process where I get into their email accounts, mine through their life. I mean, when if we think about all the information that's in our email, using that account access maybe to reset passwords, because if you think about how many websites we have access out there where we say forgot password, click the link, get the link into our email, and then click on that and get back into our account that we've forgotten the password for. So using those account takeovers to get access to new passwords, to get access to new accounts, to send information between people that would trust each other. An issue back to the Iranians again. Iranians trying to get into a satellite company in the US, unsuccessful, hacking in the front door. So ultimately broke into the company that was hired to do the weather forecasting for the satellite company. Took one of those weather forecast emails, weaponized it, attached some malicious software to it, and sent that back into the satellite company to the person whose job it is to open emails with weather forecasts from the weather forecasting company. So the idea that I can train people to avoid phishing attacks went out the window with some of this advent of artificial intelligence and account takeovers, deep fakes, all of that. Because now we don't have to defend against a Nigerian prince saying, send me your social security number and give me your bank account, and I'll send you $200 million. We're dealing with people whose job it is to open attachments from people they don't know. I mentioned a while ago Fin7, the group that was doing the credit card attacks. Rather interesting account takeover and phishing attack that they were famous for was getting into hotels like this in order to steal credit cards from hotels. They would send in a message to the group reservation department at the hotel with the form for group reservations that was downloaded from the website, but weaponized with some malware on it. And what group reservations person in the right mind would not open an attachment from somebody that says, I'd like to book a wedding at your hotel with 40 people. Here's your form. I filled it out. Best part about that one was they had a call center set up and a number in the email so that if you had problems opening the attachment because it's coming in from other sources in other countries, you could call the number in the email and they would walk through installing malware on your computer in order to get access into the computer. So getting back to our lightning strikes, that concept of being able to avoid the attack has also gone out the window. It really is about when the attack occurs, how fast can we detect it, and what are we doing to minimize the impact of the attack. Just to dig into a little bit the ransomware, because that seems to be on everyone's mind, and the questions of what is ransomware at the end of the day, and how can we protect against it, and what are we going to do if it occurs. I've always enjoyed physical world analogies. It just makes more sense to me, this whole cloud, virtual machines, and everything else. I get it, I understand it, but it makes more sense if I can touch it and feel it. So a ransomware attack, much like you walk out in the morning to get in your car to go to work, and there's a boot on your car, and a note on the windshield that says, send me $500 and I'll send you a wrench. That's ransomware writ large. If you send a note, or if you send $500 to the threat actor, they will send you a wrench. It's their business model. If they didn't send you a wrench, the next person that comes out sees the boot with the note, they're not going to send the money. So it is their business model that if you send them $500, they will send you a wrench. The wrench doesn't necessarily work all that well, but you do get a wrench. One of the challenges is when you use the wrench to take your boot off the car, you may find out that the rim got scuffed up a bit, maybe the tire got popped, so your systems still need to be put back together again. It's not this magic silver bullet where you can just magically take the boot off and drive off. You still have a lot of repairs to do on your car. So one answer for that is having a magic button that you could push. Your driveway flips over and your James Bond Aston Martin is sitting there in your brand new car and you drive away. So that's your backup and recovery software. The idea that that could occur, the threat actors started getting less and less revenue from ransomware attacks because IT companies, IT people got better at having that magic button, driveway flips over, drive off, don't have to pay for the wrench anymore. So the threat actors then started taking pictures of all of the data that's in the car while they had another team putting a boot on the car tire. And now, not only would they charge you for the boot and the wrench, they would charge you to delete all the pictures they took of the data in the car. So that became a double extortion attack in ransomware. Sorry.
Yeah, so thank you. Thank you very much. So I'd like to ask you a question about the ransomware. I had read recently about a case study of United Healthcare, and in terms of how it's related to ransomware, but I think it seems more relevant in right now. But I wanted to know if you're familiar with that.
I am, and it is very relevant.
Can you elaborate, please? That'd be
Sure.
wonderful. Thank you.
Certainly from United Healthcare and Change Healthcare, United Health Group occurred at the same time as MGM, Caesars, Clorox. The threat actors were going through all those organizations at about the same time. The Change Healthcare attack was interesting for a couple of reasons. One, it was a double extortion attack. The threat actors encrypted a bunch of systems in the network, and they also stole a bunch of data. Change Healthcare's predetermined decision was that they would pay the ransom in order to try to prevent the disclosure of the data. We didn't work that incident response, but from what I'm aware, they were able to recover their systems without needing to buy the wrench and take the boot off. So they had the magic button and the flip over and the Aston Martin, and they were able to get back up and running. Still takes time. Still need to put all those systems back together again. Maybe you find out that your Aston Martin hasn't been driven in 4 or 5 months and it needs gas and the tire's a little low. And so you have to still go through that process. It took them 4 or 5 days to recover their systems. But the real reason for their ransom payment was to try to avoid the disclosure of all of the patient data that had been taken. Somewhere 100 million to 190 million records were taken out of taking pictures of the car. Interestingly, ransomware groups started this concept of ransomware as a service 5 or 6 years ago. So now instead of me having to write the code, write the encryption malware, find a dark website to post this data, go through this whole process, I could, just like we buy Microsoft Word from Office 365 and use software as a service, they have ransomware as a service. These threat actor groups just resell access to their tool. And when you do an attack, you pay the ransomware provider, the RAS service provider, 20% of anything you take. In this case, Change Healthcare paid the ransom, paid $20 million ransom. The ransomware as a service operator said, so long and thanks for all the fish. He said, I'm retiring on this money. I'm not going to pass on the 80% that I'm supposed to the person that actually did the work. I'm just going to take it and run. The threat actor that actually had the data went back to Change Healthcare and said, hey, I haven't been paid. You paid the wrong people. Change Healthcare said, look, we're not going to pay again. We're not a recurring target here. So the data ended up getting released anyway. So that is the risk, that you are dealing with criminals. Like I said, generally you send the money, they send you the wrench, but that data exfiltration and the data attack became a different strategy.
That's incredible. And is that common?
Again, after that ransomware group folded up and went away because no one was going to trust them or deal with them anymore. And then other groups came up, and they all have their ratings. There's ones that we would say are more reliable, that they're more likely to keep their word.
Right.
But that's a challenge, that you're dealing with criminals at the end of the day.
There's a Yelp in the dark web.
Effectively, yes.
Amazing.
With ratings and...
Rating. Thank you. Thank you very much.
So interestingly, Coinbase, we talked about them a minute ago, they had a very novel response to the threat actors. They had this issue. They were ransom demand to Coinbase. And Coinbase also said, we're not paying. Learning from Change Healthcare, hey, even if we pay, you might use, disclose, sell the data anyway. We still have to notify everyone. We still have to go through all those protection steps. What do we get if we pay the threat actor? So Coinbase's answer stood this on its head a little bit. And this is the first one that I'm aware of that came along, and they said, we are going to have a $20 million bounty for information leading to the arrest and conviction of the people that did this. So Coinbase, instead of paying the ransom, now has put out a tips award for $20 million leading to the arrest of the people that attacked Coinbase. An interesting way of dealing with the problem, but it is that challenge of when we have something happen, then how are we going to respond to it, and what is our story? How are the steps that we took to prepare over the last 10 years, 5 years of technology choices and risk solutions that we're looking at to prepare for our response to the threat actor? So just briefly, we can talk about some of the security layers and controls. And I think important to think about and to realize how all of these controls come together. Because as we're making executive decisions, whether it's at a board level, leadership level, strategic level, a tactical level, we should be thinking about the effectiveness of the controls and really looking at and understanding how these all work and relate to each other. We could make this room super secure by not having any doors in it or windows. We could make our computers very secure by running them through shredders. They would be perfectly safe, not very usable. So ultimately, we need to have some means of getting access to our data. So that's these gaps in the controls that we're seeing in this image here on the left, with the idea that we have doors in our walls, we have routes into an environment, we need remote access, we need customers to be able to access bank accounts, we need customers to be able to access portals, we need to interact with our services. Similarly, we can have guards watching certain areas, but there's a balance of how many guards per how much activity. Do we have one guard per user? That would not be very effective from a business perspective. It would be a little intrusive to follow around and watch exactly what they do. So we have to play a calculus, a math game at the end of the day, to try to assess what the right levels of security are for each control layer. And the challenge for us is to figure out how those controls stack up so that when the threat actor makes it past one set of controls, that we have an opportunity to detect them and they can't run really, really fast. Again, if you think about that driveway, if we think about layered security, if we have a gated community and then a fence around our yard and our car is in the garage, then it's not that the threat actor couldn't get to our car at some point. It's that hopefully the guard at the gate shack at the entrance to the community would have called us and said, hey, I have a delivery here for you from Domino's. And I would say, I didn't order Domino's, don't let them in. Or maybe I did, and I would say, okay, I'll let them in. Is it the right Domino's though? So I would have multiple opportunities for detection as the person keeps moving through the environment. But having those systems and being able to review them and log them and monitor each of those layers ends up adding complexity and requires that internally our business units and our people have to work together and communicate with each other. Because you certainly have application developers who do a lot of work in the manufacturing space. You have general managers that are measured on their throughput. How many widgets am I making? How many pieces of material am I pumping out the door and I'm shipping out the door? But when that general manager says, I can't provide as many, I didn't get 1,000 widgets out the door, I only got 900 out the door because these security tools got in the way. Or when the salesman comes in and says, I lost a big deal because I was trying to update my slide deck at 2 o'clock in the morning and got locked out of my account. So that's where the friction comes between security and business usage. And it really requires us to have some great conversations between the security teams and the business teams and the IT and the development teams internally. And that's these control layers and the interactions that become some of the metrics and some of the key performance indicators that boards look for and executives look for to figure out how all those systems are working and what should I be trying to measure and demonstrate that I have a reasonable set of security controls internally. That middle chart starts talking about how the threat actors view the world. So when a threat actor starts looking at an environment, they're going to have to do some reconnaissance. Then they're going to have to weaponize their knowledge, whether they collect passwords and then get access to passwords and start using them against the environment. Similar gated community, I'm going to have to figure out how to find the clicker to get past the gate. Once I make it past the gate, I'm going to have to get to the house and I'm going to have to drive up and I'm going to have to start putting that boot on the car. But it's kind of noisy and it's heavy and I'm lugging it up and it's clanking a bit. And if there's a dog inside that starts to bark and I listen for a second and see if any lights go on, so I can establish some persistence into the environment so I can do my work. And that's another detection opportunity. As I start getting into that persistent side and I come back into the environment and now I know how to get in, I know how to get to that car, I know how to defeat the guard dog, maybe I bring him some peanut butter. Then I start figuring out that lateral movement. How do I use that access to this one part of the environment to get into other parts of the environment? whether that's my weather company into the satellite company example, whether that's stealing information from one company that gives me a lot of information, background information, that allows me to file unemployment claims against a state, or to file a false insurance claim, or open a bank account, or start a mortgage, or lets me start collecting information and pulling it together from multiple sources and start making these lateral movements. And then ultimately launch my end game attack, launch my encrypting malware, launch my information theft or disclosure, or intellectual property attack, or build a competing fighter plane or ship because I stole the plans for technology. So whatever that end game and execution attack is. And then there on the right-hand side, looking at what is risk. So as we start talking about risk being high and low, and how do I affect risk, one of the questions that we're getting a lot of right now is, I spent $20 million last year on my cybersecurity program. I'm being asked to spend $20 million this year. Is that the right number or not? Should I be spending 25 or 15? Because my risk level is still high. And if my risk level is high and I spend 30 and it's still high, have I really done anything? Or if I spent 10 and it was still high, have I done anything? So understanding the background behind what we talked through, the threat landscape, attacker motivations, and looking at how that changes your threat landscape, the impact of an attack, the vulnerability to those attacks, and ultimately the likelihood of all this occurring, those 4 factors making up your risk picture, and figuring out how to apply those 4 things, and hopefully some of the conversations we had here of how threat actors work, why they're doing what they're doing, and how they do what they're doing, to get into an assessment of risk so that we can have a good conversation on reasonableness, on what our real risk is, and then ultimately what we're spending on our cybersecurity controls. So I hope that gave you a little bit of background on the threat landscape and who's doing this and why they're doing it, and in some of the issues that we're facing today. And I know we'll have a lot more discussion with Al, but certainly happy to dig into any questions you might have as well.
Thank you. I was trying to find my on button. So this is becoming more frequent as technology grows. And we're starting to see a lot more businesses provide, whether it's like credit checks or things like that. I personally have like a digital credit card where all of a sudden I get a response saying, hey, we don't know what happened here. We're going to send you a new security code and a new credit card number just within seconds. Do you see more companies putting that type of security into their business models with the growth of cybersecurity, or is it still sort of like we're not going to, or like they're still weighing the cost effectiveness of it, or things of that sort?
I think security by design, and that concept of providing security as a saleable product, has now come to fruition. We have credit cards, you see advertisements for use, Discover, because you can freeze your account. So, choose my card because I'm more secure. The advertisements on the secure browser, choose my Safari browser because it's more private. So those concepts are definitely becoming a saleable picture. It's interesting, something you mentioned there, though, that the credit card companies were one of the first ones to that pitch, that game. And the reason why was it was really their money at risk. When a credit card gets stolen, you weren't going to pay your bill, right? You look at that and go, that's a fraudulent charge. I didn't buy that lawnmower. I'm not paying it. So it was the merchants that were losing the money, the banks that were losing the money, the credit card companies that was losing the money on it. So they were high financially incentive to fix that problem. one of the challenges that we're getting into today, and something that regulators are trying to crack down on, is if you have an account takeover and you have something we just dealt with in California, a lady was browsing the internet, went to a site that she Googled, but it turned out to be a threat actor site instead of the legitimate site. In going there, a message pops up on her screen: "You've been hacked, call this number." Calls the number. The threat actor convinces her to that she needs to withdraw $40,000 from her checking account in order to protect the money because of the war going on in Ukraine and the banking system. She's supposed to withdraw the money, and the Treasury agents will come to her house, give her a Treasury check, and pick up the $40,000. And she does this and goes through this whole process, and now she's out $40,000. But that is now her problem. It's not the bank's problem. It's not anyone else's problem. So that's still some pressure there, because the banks aren't necessarily driven to fix that problem, because there's too much friction there. It's too hard to put enough layers of protection in, and the regulators are starting to push back and require that people do a better job in doing what they're calling customer identity access management. So making sure that you know who your customers are. So absolutely right, saw that on the credit card side of things. The push there was because it was costing the credit card companies a lot of money. The next layer that the threat actors have found, because they've shifted away from the credit cards because it's less value to them now. If I steal a credit card, I can't make as much money on it anymore because it gets canceled in 10 seconds anyway. So a shift directly towards those ways that people, the threat actors, can get access to money directly from people through those payment redirections, payroll deposit redirections, things like that. And that's still an area where we're being challenged to defend against it, because it's individual losses that each person is losing a little bit. There's no one company that's losing tons of money to the point where the credit card companies would come in and say, "Holy cow, it's costing us billions of dollars. Let's fix this problem."
And then just clarify, I don't know if you know the answer to this one, but so if I think of school employees, because obviously I am one, and we don't make a lot of money, but say our bank accounts get hacked, and I lose $2,000, whatever's in there. Do banks insure that? Or
so my understanding, I'm not a banking expert, but my understanding in the US banking laws are that that's not the bank's responsibility. So the bank may cover that, but they don't have to cover that. That's changing in Europe. The Europe regulations, the bank is being responsible for it and has to cover it, at which point they could insure against it and those type of things. But to date in the US, I don't see a lot of banks insuring against it because it's not their responsibility, and they're taking it on a case-by-case basis as to whether or not they would cover it. From a threat actor perspective, the US banks are getting better at following the money and pulling it back. So in that case, if I stole $2,000 out of your account and moved it to another bank, and then moved it to another bank, if you notify law enforcement fast enough, they can follow that and start pulling the money back from the various banks. And at some point, 90, 120 days from now, you might get your $2,000 back. From a threat actor perspective, I'm going to try to move that money offshore to a bank that doesn't respond as well to those requests. And that's what Hush Puppy, that image that we saw in the guy in the purple jacket leaning against the car, that's what he was really good at, was moving this money into banks in Africa that wouldn't respond to those requests.
Thank you.
You mentioned, just as a follow-up there, you mentioned insurance, and it is interesting. Insurance has been getting harder and harder to get and more expensive, and we're seeing insurance companies look for reasons why the claim maybe should be denied, with the idea that 10 years ago, you could buy insurance for almost nothing for cyber events. But what was happening was the payouts in those were getting larger and larger and larger. So we've seen insurance companies start pushing back and saying, well, in your insurance questionnaire, you told me that you had multi-factor authentication in place. This event occurred. In your forensic report, it says that the threat actor was able to get in because you didn't have multi-factor on this one system. That's clearly not what you said in your questionnaire. Maybe we're not going to pay that claim. So the insurance market has become a lot more complex as well, and they're requiring things like tabletop exercises and different levels of and layers of security controls before they're able to issue insurance to you. Thank you.
So I think I was going to follow up on Mr. Palkey's question. So your question, if I'm correct, was that somebody got in your bank and just took $2,000. Is that it? It wasn't like, hypothetically, it wasn't a, well, no, me too. Me too. I'm right there with you. I'm a state worker. So, but I'm, so rather than they got your debit card and bought something or spent it on something, they actually stole it out. Is that what you're saying? Or the bank got hacked. And that's when you're saying that the bank isn't responsible for that at that point.
So if the bank got hacked, the bank would certainly be responsible for that. But most of the time, I've worked one issue maybe in the past 20 years where the bank got hacked, resulting in money being taken out of people's accounts. Most of the time, it's that I maybe find...
He gave the money to the prince, is what you're saying.
Effectively,
basically.
yes. He gave his password.
Yeah.
He gave his password to the prince, who then logged into his bank.
Okay.
And withdrew money.
A
But
better
if-
example would be if they stole your mail.
Oh, yeah.
Okay.
And
you
it's
got
not our
that.
fault either if that happened. Yeah.
But it's your responsibility to make sure that you have a secure place to get your mail. So the bank. the
No,
onus is-
I have seen our boxes getting broken into. Just saying.
Yeah. Yeah. But in that case, the bank doesn't feel that they have a clear responsibility to pay you back.
Right. It's more the post office. Can you get the money from the post office? That's a big no.
Yeah. Yeah.
But that's the challenge for us from a password perspective is that it's difficult. We have 500 accounts, finding different passwords for all those different accounts, because what is your username? It's probably your email address or your first initial last name or something like that. What is your password? If it's the same password that you use for your LinkedIn account or for your
Yeah.
DoorDash account or whatever, or even close to it, then a little bit of artificial intelligence. I can take the 10 passwords that I can find of yours online from breaches in the past 10 years from T-Mobile, Verizon, Hilton, Marriott. You can write down the list.
Yeah.
I can run all those through an AI algorithm and predict
Which
what your
password it is.
could be. Try those. And this gets back into the security through obscurity. I can try 1 million passwords against 1 million different accounts, and it works 100 times.
Well, yeah, it's a
And then
numbers
I get
game.
2,000 each, and I just made my money for the year.
Yeah. So then you also said that we are not seeing as much. So like phishing, teaching or, running phishing exercises like at CalPERS isn't something that's going to garner anything anymore because they don't really run phishing exercises, or we should still run phishing exercises.
That's a yes on the phishing exercise.
Got it. I figured that was a question for Al.
No, the point really was that the easy to notice scams are going out the window. Like the ones that say, hey, I'm going to give you $100 million, just send me $20,000. Those are going out the window. The ones that are coming out now are targeted. They know your name.
Yeah.
They know your name very well. You know that.
Sorry. Right now, they're just trying to get money from other people
From
using
other
my
people
name.
Using your name, right,
Yeah.
exactly. So it's much more targeted. They know a lot more about you. They don't have the grammatical errors that they used to have. they're very well constructed, and if they've compromised an email account, they've been monitoring your account for a little while, so they know who you interact with. So they know a lot more about you, so they're much better. The social engineering.
How many times do you have to change your
is much
damn
better.
password, man? Then the last question I had was, you also said that it's getting to a point where they're not like stealing your credit cards as much because they're not getting any money out of it because it gets canceled right away. However, it wasn't too long ago, couple months, I don't know. Yeah, I had a fraudulent charge on my account and had to cancel my credit card. And yeah, so it's still happening.
Still happening. The value of a credit card, though, has gone down on the dark web.
Right, so
I
those
used to-
numbers anymore don't count as much, or they do a little bit, but
it's not as profitable anymore for the threat actors. Much more profitable to steal information that would let me make a synthetic identity and then resell insurance access to insurance claims to get knee operations and plastic surgery is big right now with going online and
would
you
never
want
have thought of that.
discounted plastic surgery. Hey, I'll give you a coupon for a facial or facelift, and using stolen identities to get that and support those operations.
Wow. Okay. Well, that's depressing. And
sorry.
No, I mean, we need to know this stuff, right? It is reality. So it's nice to know. I mean, now it makes me want to go home and change all my passwords all over again. But anyway, yeah. Has anybody got any more questions? I'm trying to kill time by talking, but it's not working.
You're only 4 minutes. You're good.
Okay. All right. Well, I want to thank you, Al. I want to thank you, Serge. No, I don't have any public comment either. Thank you very much. Great presentation. I think it sort of piqued all of our interest. So thank you very much. And I want to give you guys a hand. We are going to go after this, we are going to move into closed session. So we'll recess now into closed session for the information security update and cybersecurity briefing. Pursuant to Government Code Section 11126, Subdivision C 18A, the Board of Administration needs to approve meeting in closed session for the information security update and cybersecurity briefing. The Bagley-Keene Open Meeting Act requires at least 2/3 of the board members present to vote in order to hold a closed session to consider matters posing potential threat or criminal activity against CalPERS property or equipment, including electronic data where disclosure would compromise CalPERS security. Based on consultation with our legal office, discussion concerning CalPERS information security and cybersecurity qualifies for this closed session exception. After the closed session, the committee will briefly report in open session that we met under this exception and if any action was taken. What's the pleasure of the committee? It's been moved by Mr. Palkey, seconded by Yvonne. Do I have to have a roll call vote? Okay, all those in favor say aye. Aye. All those opposed? Any abstentions? All right, the ayes have it. We will move into closed session. So if we could clear the room, thank you very much. We will see all of our folks at 8:30 tomorrow morning. received an information security update and cybersecurity briefing. No action was taken, and this adjourns today's meeting. Thank you, everyone. Day 3 of the offsite will begin at 8:30 a.m. tomorrow. I will see you all tomorrow. Well, I'll see you tonight.